My name is Mayor Dan Raynard, and I would like to first start by acknowledging that we're hosting this meeting on the traditional territory of the Anishinaabe people, as well as shared territory under Treaty 3. Given the tremendous response to such a forum, this is the second forum today that has taken place. We're very fortunate that today's forum, the presentations, what the group had done and requesting the questions in advance. And so what it allowed the presenters to do was to formulate the presentations that addressed a lot of the questions. So we had a very positive forum this morning. The questions after the forum were respectful, they were well pointed, and hopefully we'll continue that this evening. For those who were unable to attend either of the sessions, they're both being recorded and will be posted online for viewing later on the City of Kenora website. I'll be moderating this forum, for which there will be approximately an hour and 45 minutes dedicated to presentations by representatives from the OPP, Northwestern Health Unit, KDSP, Nietzsche Friendship Center, and the City of Kenora. Q&A period will follow the presentations, where members of the public will be given the opportunity to ask questions to our panelists. I'd like to reiterate the purpose of this meeting is to provide information about the social challenges affecting community safety and discuss where opportunities for change are present. I'll reserve the right to stop off-topic or out-of-order discussions during the Q&A period. To ensure this remains a respectful and polite meeting, I would ask that the following ground rules be followed. For everyone that has a cell phone, would you please turn them off? For the question and answer segment, I would ask that speakers please line up at the microphone. We'll have one on each end of the group. And when you come up, I would ask that you give us your name and then who you're addressing your question to of the panel, and then give them the question. If a question cannot be responded to, it will be noted and a follow-up response will be provided as soon as possible. We'd ask that there be no side conversations during the presentations. Our first presenter is Jeff Duggan, the detachment commander of our local OPP. Jeff started his policing career in 1998 with the cadet program in Kenora and was hired as a constable in 2002. He's worked in the Northwest region for his entire career in a variety of different units such as crime and Kenora Detachment Operations Manager. He was born and raised in Kenora and is married with 3 children. Actually, they all look spitting images of Jeff at just different sides. Scary. So welcome, Jeff.
Adam told me I had to turn this on, and I said, I'll throw my whole presentation off. Can everybody hear me okay in the back? I just want to make sure everybody can hear me. If you can't, if you could just throw up your hand, that'd be great. I don't want anybody to miss anything. First and foremost, thank you everybody for attending this forum tonight. We did have a forum this morning that was just as well attended as this one, so I'm really glad to see that people are taking an interest in our community safety and our community itself. What I'm going to do today is I'm going to run through what I wanted to do was just break down for people some of the legislation that the OPP uses to enforce the laws in the city, what we can do, what we can't do, things we won't do because we can't under legislation, and really just give you some brief stats on our calls for service and so forth. Don't rush out to take pictures. I believe these will all be made public, so by all means you can take pictures if you want, but they are going to be made public. So again, thank you very much. We'll have to cut my presentation down, so I'll get right to it. So just for everybody's knowledge, everybody sees the black and white cruisers driving around, so I wanted to give everybody a kind of a picture of what our detachment looks like. So there's myself, I'm the detachment commander. We have 2 staff sergeants, one in charge of operations and one in charge of human resources. We have 9 sergeants that are scattered between different specialty units, the general law enforcement officers on the road, the court office, and so forth. So our total complement of officers in Kenora, the Kenora Detachment, is 84. Now that doesn't mean there's 84 officers assigned to the city of Kenora, because the OPP Kenora Detachment does look after not only the city of Kenora, but down to Nestor Falls, as far north as Moonachie, Reddit, and of course all of Lake of the Woods and right to the Manitoba border. So to say there is 84 officers, we do a lot of our work based on analytics. So a lot of our work is in the city of Kenora, but we do respond to calls outside of the city of Kenora. You'll see there we have 8 vacancies. I put that on there as a matter of just so people know that we're not unlike any other police service. We do have 8 vacancies. But what I will say about those 8 vacancies is although the OPP is under some budget reviews, the OPP and the provincial government have committed to filling all of those 8 vacancies. And they've actually committed to filling vacancies throughout the Northwest region and the Northeast region. So as our recruit classes go through, those vacancies will be filled and we will be at full complement. So that's unheard of in my time in policing. Normally detachments carry 5 or 6 vacancies, just as a matter of turnaround. But the next class that goes through our Ontario Police College and our academy will have 48 recruits, and they'll all be coming to the Northwest and Northeast regions. A little bit of historical data, calls for service. So you'll see it's broken down in the top chart from 2014 to 2018. We are seeing a dramatic rise in calls for service, and that's attributed to a number of things. I know there's been a lot of social media talk about methamphetamine. There are a lot of crimes associated to that addiction. There are a lot of crimes associated with substance abuse and mental health. Some of our key top priorities in the city. So we are seeing a rise in calls for service, and certainly from 2014 to 18, a significant rise. The bottom chart represents 2018 and 2019, basically January to June. So you'll see we do have a rise in calls for service, and that's just for the city of Kenora. So that doesn't account for anything outside of the city limits. That is just for the city of Kenora. And they're broken down into the billing categories, just for interest's sake what they are. So the billing model is a whole different animal, and I can certainly explain that, but I don't want anybody to fall asleep on it. So I would take you through the Liquor License Act, and I know people are likely familiar with this act. So section 31.4 of the Liquor License Act and 31.5 of the Liquor License Act, that speaks to people drinking in public and people being intoxicated in public. And as you'll notice, it is the Liquor License Act. So this section deals with liquor. Currently there are other pieces of legislation, but one thing we're pushing with the Solicitor General and other government agencies is to create us a law that covers intoxication as a whole. Not just liquor, because we know we can be intoxicated on any type of drugs, any type of solvents or lacquers. And that's slightly unique to the province of Ontario, because when you go west into Manitoba, they have the Intoxicated Persons Detention Act, and it covers all those things. So that is the section that we use, albeit we've had numerous inquests that say we have to reduce the use of this section to lock people up in jail. And as a matter of what happens when somebody's arrested for public intoxication. Prior to 2016 and further back, people were taken to jail. They were locked up for 8 hours, 6 to 8 hours. They were put in a cell. They weren't provided any services. We fed them, we gave them water, but it was basically just lock them, watch them, and it was just a cycle of, it would happen every day. It could happen twice a day for the same person. So when we took a look at that, we said, well, we can't, this isn't an effective use of resources. This isn't the right place for somebody. So now we have an agreement with the Morningstar Detox Center through the Lake and Woods District Hospital that all of our non-violent intoxicated people go to the Morningstar Detox. And the reason they go to the detox is because they're providing services at the detox that we can't offer. Right? They have counseling services there. They have a managed alcohol program there. They have counseling services for people that have substance abuse problems. So that is what we do. The person can be lodged in cells, but it's not common practice. The only reason somebody would be lodged in our cells is if they're violent or they're banned from the Morningstar Detox. And when they're banned from the Morningstar detox, it's not that they're banned for life. They're banned for something that's happened there, and they can't go there. Those are reviewed constantly by a group of OPP and staff from the Morningstar detox. The people can be taken home if somebody's there to take responsibility for them and ensure that they're safe. So what does not happen in most cases, a number of years ago, certainly prior to my policing career, people were given provincial offense notices for being intoxicated in a public place. And after you collected so many tickets, you were sentenced to a jail sentence. And that doesn't happen anymore. And that's R versus Hill, which is case law. That is not an option for us. We can give out provincial offense notices to everybody that we arrest for public intoxication. A couple things have to happen with those provincial offense notices. They have to be processed by the courts, and then they have to be tracked. So we do not give provincial offense notices for being intoxicated in a public place because people don't have the means to pay them, and it's fruitless. They don't go anywhere. So I know this is hard to see, but like I said, this will be provided for everybody to look at. So this is a chart of the amount of people that we lodge in our cells versus the amount of people we take to detox. Like I said, the program started in 2016, and this is till March. So the green line represents the amount of people per month that we take to detox, and the blue line represents the amount of people that we actually lodge in our cells. So you can see as we work through 2017 in the summer, we're certainly taking a lot more people to the detox center as opposed to our cells. Now, the number of people that we're lodging in cells, you'll notice in March 19, it is creeping up, and that is the methamphetamine that we're seeing in Toronto. So people that are maybe intoxicated on alcohol and have methamphetamine on board and they're violent, like I said, we take them to our cells. And we fully recognize that that's not a good place for them either, but we are working with the Lincoln Woods Hospital, the Morningstar Detox, and other agencies in Kenora to see if we can find a place that we can hold these people as well. This is an overall chart, 2012 to 2018, on the total number of arrests and lockups for intoxicated people. As you can see, this number is going down. And why is this number going down? It's because of the partnerships that we've built with other agencies in the city. You'll notice when you're driving around Kenora, if you've been here for your entire life, you used to see certain people around town. We don't see some of those people anymore. And it's not because they've passed away, it's not because they've moved away, it's because we have a complex client care group that meets. And what we do is we compare our stats of arrests, interactions with police, fire, ambulance, hospital, and those top flyers on that list, we develop a plan. It's an individualized plan for them. Where can they go? Who can help them? Who can assist them to get through their time? So they're not on the street. So they're not abusing alcohol or drugs or whatnot. So it's been really successful for us. And one person that we might pick up 2 or 3 times a week, if we can get them help, that's why you see those numbers decreasing. So that is happening in the city of Kenora. The Trespass to Property Act. So I put this in here because there's a lot of comments online and on the pre-questions about what can we do to get people off our property? How can we get people to stop sitting on our stairs, to stop laying in our lawns? The Trespass to Property Act says that you can ask them to leave, and if they don't leave, they can be charged. But it's really, what it does say is that onus is on the occupier of the premise or the owner of the premise. Now, I'm not asking everybody to go out and ask people to get off their chairs. If you don't feel comfortable doing that, then call us, and we will certainly do that. But if you put a sign in your business, or if you're living close to where it's a problem, if you put a sign outside, and we drive by and we notice somebody sitting there that is not supposed to be there, that sign gives us the authority to ask somebody to move. It could be as simple as no loitering. I did put some, something as simple as that. And you can make those yourself. You can order them online. You can even throw that in the printer and print those off. And something as simple as that will allow us to go by your business or residence and say, excuse me, do you live here? No, you don't. What are you doing here? You need to move along. You're not allowed to loiter here. Again, this is just the plain language for the Trespass to Property Act. So it starts with the occupier asking somebody to leave. If that doesn't happen, you can give us a call. We will come to your house or your business or wherever you are and ask you, do you want this person to leave? You say yes, then we're acting on your behalf. Again, that just talks about the size of the sign and everything. It's all online under the Trespass to Property Act, Section 3. So what we can't do, we often get calls from people that say, there's somebody sitting on a park bench on Main Street. I don't want them sitting there. They've been sitting there for 10 or 15 minutes. We have no authority to move them off of public property. Unless they're doing something wrong, then we have no authority to move somebody off public property. So like I said, drinking in public, urinating, using drugs, that gives us cause to go up and talk to those people and tell them that they can't do that here and they have to move along. Now that may lead to criminal charges or so forth, but it is definitely something we cannot do. We can't be everywhere all the time. People say, well, didn't you see so-and-so? He's been sitting here all day. We can't be everywhere. We're really relying on the public to call us. We are increasing our foot patrol. A large part of our patrol area is the downtown core. But we do need people to call us because we can't be everywhere at once. If you call us for a Trespass to Property Act call, we may not be able to respond immediately. We get emergency calls for service that take up resources, and we can't always immediately respond. If you call us, we will respond. Those calls sit in the queue, we call it, and if those calls will be answered. Depending on other priority calls, they'll be placed in sequence by our shift sergeant or by our NCO that's working. And we will respond if there's no other higher calls or priorities are in progress. And I will tell you that so you have your shift working, and then of course there's people in the office like myself, the other command staff that's here. If we hear calls stacking up, we all went to the same police college. We'll go out and do calls too. That's something we do regularly. I put the Safe Streets Act in here. This is a section that we do use, but we usually use it in conjunction with some type of project. And we have used this in a project at the mall, and it was quite successful. It talks about threatening people while soliciting. It talks about obstructing the path of a person soliciting, or that is soliciting, obstructing a path, using abusive language during the solicitation. It really has a myriad of sections that we can use, and we will use it. There is a section in the Safe Streets Act that also talks about discarding needles. And before everybody gets too excited, that section is not used very much. It's a found committing offense. So I can't submit a needle to our Center of Forensic Sciences and get them to test it to see who used it, who discarded it. But if we see somebody and they blatantly throw a needle on the ground, there is a section to deal with that, and we have done it. We're also working with the health unit to educate people on this section. We talked before about putting a pamphlet, with the needles that are given out to say it is actually an offense to do that. So, causing a disturbance, again, by fighting, screaming, shouting, swearing, singing, or using insulting or obscene language, or by being drunk or impeding or molesting other persons. We do use this section. Typically, we'll use it to make an arrest to end the disturbance, and then we will release. We could make dozens of arrests daily on this section, but if we did that, we'd be going back to the government and asking for more crown attorneys, more judges, and more jails. And it's just not feasible. So there are other sections that we use other than the actual criminal code section. Breach of the peace. So this section was created for like civil unrest type occurrences. And the interesting part about this section is once the breach of the peace is over, the officer must release that person. So this doesn't actually give us the powers to lay any charges. Big topic of conversation, or big topic in the questions that we had were, what can be done to reduce the crime and disorder and calls for service. So we are increasing our foot patrols and our police presence in the downtown core and throughout the community. We're heavily based on analytics, and if our analytics tell us that there's a problem area or a high crime area, we will increase our foot patrols. We will increase our patrols. We have 3 analysts that work in Thunder Bay. We have one that works locally here. That's all they do is analyze crime and crime trends. So we will adjust where we're patrolling based on crime trends. Working together as a community to solve the root cause of these crimes, which is mental health and substance abuse. I'm going to get into some of the things that the OPP is involved in. They're not directly related to crime, but getting to the root causes of crime will help us in the long run. We need to provide the supports needed so individuals can break the cycle. And when I talk about the cycle, I'm talking about the arrest-release cycle. We need to give people the opportunity to forge ahead in their lives. We need to give those people the opportunity for housing, for jobs, for schooling, for things like that. So we need to help these people break the cycle that they're in. We're working with residents to have them report all crimes. We can't investigate something that's not reported to us. And contrary to popular belief, we don't monitor social media and respond to calls that way. You have to call us if you want the police to come. You have a number of options, which I'll go over after, for emergency, non-emergency, and just to say hi numbers. We cannot respond to social media. So we do have an internet reporting tool, but that internet reporting tool is for insurance purposes. If you want to report something, you go to opp.ca, you can report your crime, but it is not for social media. We cannot follow. Working with stakeholders and members of both the federal and provincial governments. So a lot of the time that I spend in my day is meeting with stakeholders. We have a full-time community mobilization officer. He's one of few in the province that we have, and his job is to mobilize the community in different projects, different outreach. We have an administrative sergeant who's here today that works very closely with our CMO, our community mobilization officer. That is his sole job, is to mobilize the community to get to these root causes of the problem. Meeting with stakeholders to create individual care plans and service plans. Like I said, we do create those complex care plans. We already spoke about that. So what's being done by the OPP and other stakeholders? And this information that I'm giving you, a lot of people may not know about the stuff that we're doing. So here it is, and by all means, there's going to be a question and answer. If you have a question about any of these things, I'd be happy to talk about them. Like I said, increased foot patrols. So our numbers are up. We track all of our numbers. Every 15 minutes of a police officer's day is tracked. You have to enter that into a computer system. I can go to my computer on my couch and see what everybody did today, what their foot patrol hours were. If they're not high enough, they're getting an email from me saying, get out on foot more. We meet regularly with stakeholders that are involved in the service hub or the shelter. We do have a committee that meets every 2 weeks with Henry and Patty's crew. We're certainly very involved with what's happening at the shelter, at the service hub. Engaged in conversations with concerned business owners and residents. Really, if business owners or residents have a complaint to make about the police or how we're doing our job, this is where the rubber meets the road. It's with me. I'm going to give out my cell phone and my email later. Feel free to take a picture. And we'll talk about appropriate times to call. But it will be there. If people have a concern, and you can go on the internet and complain. I can't stop you from doing that. But it's probably better off if you call me and I can tell you why we're doing something, why we're not doing something, or if you don't like something you see, and I agree with you, I can hold somebody accountable to that. The risk table, Rapid Intervention Services Kenora. That table sits every second Tuesday of the month, and it involves 35 stakeholders. So if you picture that, it's 35 stakeholders from the community that come together and deal with people that are at acutely elevated risk. So these are people that are in serious danger, and they meet every 2 weeks. And a lot of the referrals that come from the agencies that sit at the table. And that, again, so people are brought to the table, stakeholders are identified that can help. There's meetings, there's care plans that are developed, there's interventions that happen. How can we, as a community, help this person to get out of what they're facing? We have available resources for robbery prevention. We have kits and tips. That's more for business owners and stuff, but reach out to us. We have 2 community service officers that would love to come and talk to you about, where to put your high-priced items, or where to put your cameras, or how many staff you should have, or things like that. We will gladly do that. We also do CEPTED, so crime prevention through environmental design. We have an officer that's trained in that. He will come to your business and tell you, this is what you need to do to reduce thefts. This is what you need to do to prevent robberies and so forth. We can certainly do that. I personally sit on a committee with the Northwestern Health Unit to talk about the needle exchange program, and I know Julian's going to talk more about that, so I won't, but just know that we do sit at that table, we do have a voice, and so do many other residents in this community. We're heavily involved in community mobilization, upstream crime prevention. And a lot of people, or a lot of comments I saw online were, why can't we just send people home? So, number one, I can't decide who makes Kenora home. That is not in any legislation. I can't kick somebody out. If they're on conditions to live somewhere, I can certainly enforce those conditions. But I can't decide who makes Kenora home. But there is a movement afoot to get people back to their home communities or to wherever they live, if they're released through the court system, or if they're just stuck in Kenora and they want to go home. Some people want to go home but don't have the means. There's programs out there to get people home. But the people that you're seeing that aren't from here, they want to stay here. And there is nothing I can do to prevent them from staying here. The housing first approach. We know that works, and that's Henry's ball game, so I'm going to let him talk about that. But just know that the housing first approach works. We're seeing it on all fronts in every community that has it. It certainly works. Community safety and well-being plan. Just a show of hands, who's familiar with the community safety and well-being plan that Kenora has? Right, so not very many people. That plan has been around since 2015. It is a roadmap for community safety in Kenora. We're one of the first communities to have it in the province. And it's mandated now by the government that every community has to have one. And Adam's going to talk more about it, but there is a community well-being planning session coming up in the fall. And I hope that everybody comes to it and gives their input, because that is a roadmap for how we're going to manage the issues we're seeing in Kenora. Well, what can't be done, we can't solve these issues overnight. We as the OPP can't step outside of any legislative authority. Oftentimes people say, well, why can't you just do that? Well, if there's no authority to do it, we can't do it because we're held accountable too. So I would never ask one of our officers to step outside of a legislative authority to fix any of these issues. We can't arrest our way out of this issue. You probably heard that term coined by my predecessor, who's now chief superintendent, but he's right. We can't just arrest people and throw them in jail and arrest people and throw them in jail. That's not going to work. We have to do something else. Again, we can't investigate crimes if we don't know they're happening, and it is extremely difficult to get a handle on the methamphetamine use until we have the proper supports in place for this addiction. The drug is powerful. It's new. It's happening all over Canada. There are communities all over Canada. I'm a member of the Ontario Chiefs of Police Association and the Canadian Chiefs of Police Association. This conversation is happening all over Canada. What can we do to solve this? We have drug strategies. We have our Organized Crime Enforcement Bureau. They investigate drug crimes. We have a community street crime unit who investigates drug crimes. We have a strategy. Of course, I'm not going to get into that because it's a police tactic, but just know that we do have a strategy for this. But it is not an easy thing to do. But we're reaching out to our other policing community partners to see what they're doing and see if it's successful. I found this quote in Felix Munger we work with through the CMNCP, and Adam's going to talk more about that, but we need a public health approach which would create partnerships with social services and health practitioners and aim to intervene before crimes take place. So when people talk about, well, what's the goal here? That's the goal. The goal is to intervene before crimes take place. And it's a lofty goal, but I think with the right supports and the assistance of the people in front of me and the people in the room, we could certainly try and get there. So this is my phone number. That's me. That's my address. If you want to write a letter, I don't think people write letters anymore, but by all means, if you want to write me a letter, that's my address. My office, my cell phone, and the fax. I don't think people fax anymore. My email is there as well. What I will say is that please don't call me if you want to report a crime. And I said it this morning, so for anybody here, report a crime, and I'm not working, which isn't very often, but if I'm not working, I'll likely have a fishing rod in one hand and a 2-year-old on my knee. And there's nothing I can do from there. If you want to report a crime, call 911 if it's an emergency. If you don't have 911 services where you live, there's a 1-800 number. For non-emergency or outside 911 areas, you can also call our office, and one will get you somebody at the office, and one will get you the communication center, 2 will get you somebody at the office. So if you're reporting a crime, please call the numbers on the screen, because again, we will respond to those calls, we will investigate them, and if we don't, let me know, because we can hold people accountable. So again, thank you very much. That is the end of my presentation. I probably didn't cut it down that much, but thank you for coming, and again, the most important part of this night is going to be the questions that you have to ask, and we will endeavor to answer them all, and if we can't, we will get you the answers. So thank you.
Thanks, Joe. Our next presenter is Jillian Leonard. Jillian is the manager of sexual health and harm reduction at the Northwestern Health Unit. She's been a registered nurse for 20 years and has been working in public health for the past 15 years. Welcome, Jillian.
Hello?
Yep.
It's like the morning session, no one gasped that I've been a nurse for 20 years, so it's okay. Just imagine in my head. I'm going to take about as much time as Jeff. I'm going to talk twice as quickly. It probably isn't a shocker that there were a lot of questions about the legal exchange program.
Can you hold the microphone a little bit closer?
Yes.
Thank
Is that
you.
better?
Yes.
Yeah. Okay. Sorry, I move around too, so just yell at me if I'm not. Here we go. I read every email that came into us, and thank you. Everyone who submitted questions and comments about my program, I appreciate it. The Legal Exchange Program is it's a misunderstood program by most people, and I understand that it should be. We don't all have this lived experience or this work experience, where we just inherently know these things. And I love taking the opportunity to talk to people about it. So when it comes to the Legal Exchange Program, whatever brought you in the door today, whether you already agree with the program, you kind of get it, but oh, that's some ground, or you absolutely hate it, you're coming in hot. Thank you. Thank you for coming. I appreciate it, and just like Jeff said, I look forward to the questions. I don't take anything personally, so please ask if I don't answer what you came in wanting to know tonight. John Thompson's in the front row from TDO, and he was tweeting pictures of me, and I told him he's got to get my skinny side tonight. I don't know which side that is, John. These were the themes of what I asked. So why do we have a needle exchange program? Why do we have to have a needle exchange program? Why can't we get rid of the needle exchange program? Why don't we have a one-to-one exchange? That's really common. We get that a lot. A lot of questions about what we do with the needle exchange program. How do we run it? What stats do we collect? And what about this outreach van? And what are we doing about needles on the ground? I wish our program didn't start with the word needle. I wish we were called like an HIV prevention program or something. It's what the program is for. But this is what you all think of. I'm assuming this is what most people think of when they picture the needle exchange program. There's a reason for that. It's what dominates social media. It's the images that also dominate the media. So even as local media recently, stories about the safety forum, needles weren't even mentioned in the article, and these were the pictures that were shown. The picture in the middle is a local picture, and there isn't a needle in it, but it kind of looks like there is. And I know what this does for people. I know what it does for me. I hate seeing this. I live here too, and we don't want needles on the ground, and we work really hard to not have this happen, and it happens sometimes, and we're sorry it does. But just for today, I want to broaden your perspective a little bit about what a needle exchange program really is and what harm reduction is. I've been doing this for 15 years as a frontline nurse, and then as the manager since 2010. And when I think of the needle exchange program, this is what I think of. I can talk about this program for an hour and not even mention a needle. In this picture, you see some of our valued partners, you see some of our clients, you see our work in learning about Indigenous culture and how we can provide our services in a culturally humble way so we can help people heal. You see a lot of happiness. I think a lot of people, there was somebody who came to my last session, who when we were done, she said, "You have the worst job in the world." Thank you. It wasn't my goal. This is how my staff are. We don't feel like we have the worst job in the world. We choose to work with a population that many do not, can't work with, don't want to work with. We work with severely addicted individuals every day, and we love the work we do and we enjoy doing it. So these are the pictures you're going to see in my presentation. Why do we have to have a needle exchange program? The answer is because it is globally for over 30 years now the best way to prevent HIV and hepatitis C. Those are blood-borne infections, that spread blood to blood. That is how we prevent the spread of blood-borne infections among people who inject drugs. It's the same reason we have condoms, just a different harm reduction tool. The program that we have, the needle exchange program, is mandated by the Ministry of Health and Long-Term Care in something called the Ontario Public Health Standards. This program is not mandated by the city. So there were questions about why doesn't the city deal with this, why doesn't the city shut it down or do something. This is mandated by our government, our provincial government, the Ministry of Health and Long-Term Care. There's 35 public health units in Ontario, and we all have to follow this document, the Ontario Public Health Standards. And it's in this standard, the Infectious and Communicable Diseases Prevention and Control Standard, where it says we have to have this program. This standard covers all infectious disease prevention, and the infections that I have, not the ones I personally have, are covered under this, right? So priority populations, meaning people who inject drugs, need to have access to the harm reduction services to prevent exposure and transmission to STDs, sexually transmitted and blood-borne infections. This is specifically in the standard where it mentions that. We have to ensure the availability of sterile needles and syringes. Point B, we have to provide the availability of initiatives related to the disposal of harm reduction supplies. So we are not mandated to go out and pick up needles. We're mandated to provide sharps containers. We have to provide a mechanism for people to get rid of their needles safely. We work outside of our mandate here, and we choose to do that, and we will continue to do that. Here are just some of the agencies that support needle exchange programs. I brought in my social media viewing prior to doing these sessions. Usually I keep it pretty small for my mental health. Some of the comments that recently I've been reading is that the health unit wants you to believe. I'm just here to provide the evidence. What you choose to believe and what you just decide to take from this is going to be up to you. I'm here to provide you the information. And in this presentation, I'm going to have links to all of these health agencies that are all got people smarter than me in them who support needle exchange programs. In the mid-90s, HIV started switching from the men who have sex with men, it was called the gay cancer in the 80s. It started switching into the injection drug-using population. And at that time, they were able to do really interesting research. So HIV rates were unstable, and not everywhere had needle exchange programs. So they did comparative quantitative studies when they looked at, okay, so all these cities had injection drug use, right? So needle exchange programs didn't cause it. Needle exchange programs were a reaction to people injecting drugs. What happens in cities that have needle exchange programs and what happens in cities that don't? And these were very clear, these are huge global studies. HIV rates go up where there aren't needle exchange programs, and HIV rates go down where there are needle exchange programs. Drug use stays the same. There's a common sense aspect to this as well. So if I was to offer you guys, if I was to offer an immunization clinic here today, and you guys all needed an immunization, and I gave you a choice between a used needle or a clean needle to get your injection. Nobody, right, is going to choose that used needle because there might be a risk of there being a disease on it. So that's how the needle exchange program works. There's a lot more evidence. A huge literature review study conducted in 2005, the compelling evidence that increasing the availability of needles reduces HIV. But there's no persuasive evidence that needle exchange programs increase initiation. So needle exchange programs don't make people start using needles. They don't make people use longer than they want to. They're cost effective, and I'll show you a bit of that in a minute. And needle exchange programs can increase recruitment into treatment and other supports. And I hear this provincially, I hear this nationally. People who inject drugs are often pushed to the margins of our society. They can't expect to walk into any agency or any organization and get treated well, like most of us can. But needle exchange programs do. So if you were to hear my staff talk to me as their manager, if you were to hear them talk to Jeff as the inspector of the OPT, if you were to hear them talk to a board of health member, if you were to hear them talk to one of our clients, you wouldn't hear the difference. My staff inherently believe that everyone has the same value and they treat everybody the same. And so very often, a needle exchange program is where people come when they're ready to get better. Just because we work with people who are severely addicted, it doesn't mean we don't want people to get better. And I've heard that too, that we heard someone wrote that comment that we don't care if people get better. I've read once on social media that I personally get kickbacks from Big Pharma. I wish. I don't. But it's often, we are often the way that people get better. A few more studies. I'm going to just assume you believe me by now, and you're going to get copies of all of these. The World Health Organization. No convincing evidence that needle exchange programs encourage, promote, lead to recruitment of new users, they increase in frequency, or they lead to greater discard of needles. So it's a 2012 study where they looked at Miami that had no needle exchange programs, and San Francisco that did. There was 8 times more needles on the ground in the city that did not have the needle exchange program. Enabling. So that was written down quite a few times, and I think it kind of fell across a few of our organizations around helping people and that we're enabling them. From our perspective with the needle exchange program, if people die, they can't get better. And we are here to help people regardless of where they are. And if HIV gets into our injection drug using population, it won't stay there, right? It's actually transmitted as well. The presence of a needle, if people think that the presence of a needle is what causes addiction, we've really oversimplified addiction. I handle needles every day. I've never thought to stick one in my arm. I've handled condoms a lot, and it doesn't make me leave work and I started on that track and I get where I'm going. Addiction is way more complex than that. The example I sometimes give is that I could have vodka in my glass. That could be vodka down there. It almost vodka tonight. It's not. Honest. You can go check. But I have access. I can get vodka anywhere. want, I can buy it, I don't have to risk going to jail. But I don't have vodka in my glass. And why don't I? It's because I don't need to. So needle exchange programs don't cause that. They don't cause people, it's just to keep people as healthy as they can until they're ready to get better. Really interesting. Scott County, Indiana. So this is an example recently of a place that did not have any. Needle exchange programs were illegal in Scott County, Indiana until 2015. Before they had the program, and 24,000 people in Scott County, Indiana, high rates of poverty, high rates of injection drug use. They did not have it was illegal to be caught with a needle. You have to have a prescription. They had people injecting drugs, and people would find a needle on the street and use it for up to a month at a time. This Brittany Combs was a public health nurse. There's a video of her on YouTube talking about this. As a public health nurse, she believed that people who injected drugs did not deserve the right to care. They avoided them. They had nothing to do with them. They didn't give them needles. They didn't give them support. Nothing. In late 2014, Indiana had, the CDC called it one of the worst, I've read articles that have called it the worst HIV outbreak in the history of the US. And this was huge. They had like 100 cases by December. Public health officials were pleading with the governor, Mike Pence, to declare a public health emergency and implement a needle exchange program. And he wouldn't do it. Months are going by, more and more cases of HIV are cropping up. In March, he called the sheriff, who was a personal friend of his, who was against needle exchange programs, and said, what do I do? And the sheriff said, I'm against them, but there's no way we're going to stop this if we don't implement the needle exchange program. In March, he declared a public health emergency. In April, he implemented the needle exchange program, and by November, they'd stopped the outbreak. Yale went and did a study after the fact, and if they had implemented the needle exchange program in 2011 when they had a couple cases of HIV, they would have avoided it completely. And if they would have implemented the needle exchange program in November, they would have only ended up at 52 cases instead of 250. 250 HIV cases in a city of 24,000 people. A few people wrote comments about, this is morally wrong. Injecting drugs is morally wrong, and we shouldn't promote it, and we shouldn't help people that do it. And that's how Mike Pence felt. Right? They're very strong, right? In terms of his beliefs and what he thinks is right. I did a presentation recently in a community around here where I did a presentation similar to this, and the person stood up after and said, I can't argue with you. Like I can't argue with what you're saying. Your evidence is really good, and I can't argue with you. And I said, yeah? And he said, but I can't feel that it's right. I can't. There is no part of me that can think this is right, although I cannot argue with you. And that happens for all of us, right? Our ethics, those things that are in us from our upbringing, from our religion, from our lived experience, they can be really hard to face sometimes in the face of evidence. And in harm reduction, we call that evidence versus ideology. And that's what Mike Pence struggled with. We don't have that luxury. And when we work in public health, we have to follow the evidence. There's times in my time working as a nurse here where I've, some days, working in the sexual health clinic and working in harm reduction, there's been hard days looking at the choices some people make. But their right to make that decision comes before my right to judge them. Why don't we have a one-to-one exchange? So this is asked all the time. So the idea is if Dan works in a needle exchange program and I take 5 needles in, say he'll give me 5. If I give him 10, he'll give me 10. If I give him 1, he'll only give me 1. People always assume that that'll be a way to keep needles off the ground. So a one-to-one exchange, I'm going to show you the evidence in a minute, leads to increased sharing, which will lead to increased HIV transmission. So if we follow that through, with me going to the needle exchange program, if I say I need a needle, and Dan says, well, where's your needle? And I say I don't have one, he's not going to give me one. So I'm not going to quit that day, maybe, but the chances of me going, oh, that's it, I guess, there's no needle I'm not going to use. I'm going to go get use the needle and use someone else's needle, because that's what addiction does to us. When we hit that point, we'll use regardless of the risk. And that goes against the goals of the needle exchange program. We need to make sure that people have a new needle for every time they use. This has been tried. Ottawa, when they had an HIV outbreak in 1991, They were the first needle exchange program in Ontario, and they implemented it in resulting from this HIV outbreak. They started with a one-to-one exchange. They just felt they feel comfortable with this. This feels okay. Their HIV cases continued to increase, and they were like, what the heck? We implemented this program. Maybe it's the one-to-one. In 1996, they removed the one-to-one exchange, and right away their rates dropped down to 60. And so we've all learned from Ottawa. No health unit in Ontario does a one-to-one exchange. I've read on social media, why don't we run our program like BC that has a one-to-one exchange? They don't. They don't have a one-to-one exchange. It's a common thing people say, and I don't know why. They don't. This is like kind of, this has been tried, it failed, nobody does it anymore. Except for one place, and I'll show you in a minute. Another study, California compared their needle exchange. Some did a one-to-one, some didn't. Sharing was way up in the ones that did the one-to-one exchange. This is from our national best practice document. So they actually talk a bit about the opposite, that it's not a matter of we're so careful how many you give people, we have to be really conservative. There's definitely the issue of taxpayer dollars. We have to be careful how many people take. Most people take 10, maybe 20 at a time. But we have to make sure that we're covered. And the idea of a one-to-one is outdated and unsatisfactory practice. So that is why we don't do a one-to-one. The evidence shows that we do have. More studies. Again, I'll just take you that you believe me. One-to-one exchange. So in Canada, there's someone that does a one-to-one exchange. Where are the HIV rates highest in Canada? I think everyone knows now. Yeah. No one used to know. I think I've just talked about this too often. Saskatchewan. You don't need to go to Africa to do HIV humanitarian work. You can go to Saskatchewan. It's unbelievable. Kind of said that like a tourist ad. How that works. They declared public health emergencies. Their HIV rates are at least double that of Ontario. Ontario is stable and it runs equal with the national rate. Saskatchewan is the outlier. And look what it looks like on Indigenous communities. It's rivaling, so sub-Saharan Africa is where HIV rates are incredibly higher. It's 50% of the adult population is HIV. On reserve is starting to rival that. So what happened in Saskatchewan? The yellow on the pie chart is injection drug use. So in public health, whenever we have cases of reportable infections, we look at how they got them, what were the risk factors. The yellow in Saskatchewan, so 71.4, I think, percent of all of their new cases report injection drug use. And in Ontario, that is 7.1%. This is from the Public Health Agency of Canada. That's because in Ontario we run effective needle exchange programs. Something is wrong, clearly, with the needle exchange programs in Saskatchewan. Here's what they do. They run a one-to-one exchange. So the other thing I read is that the Northwestern Health Needle Exchange Program is an abject failure. And I think that is often based on needles being found on the ground. People think that that's the goal, it's important. But it's not the overall goal of the program or why we have it. That is what Saskatchewan based their success on. So they called their program fundamentally successful, and they noted that they had a return rate of 90%. So look at us, high five, we've got 90% of our needles back. Look what was happening with their HIV rates in Saskatchewan. They were looking at the wrong thing. This is from their 2017 HIV report to the government of Saskatchewan. It continues to lead the country in rates of new cases of HIV and hepatitis C. The major risk factor is injection drug use. They are the only province in Canada that the injection drug use is the #1 risk factor. They got this part from the Canadian AIDS Society. It's estimated that each new case of HIV results in $1.3 million cost per life course. We talked in public health about chronic disease prevention. HIV is considered a chronic disease now. People are 20, 30 years in with the infection. But we talk about public health prevention. If we can prevent chronic disease, if we can prevent people from getting diabetes, if we can prevent them from getting heart disease, HIV, hepatitis C, it is way cheaper, always, than dealing with the costs that come once these people have these infections. So what does mean success in our program? We did a survey with our clients 2 or 3 years ago now, 140 clients regionally, and we asked them lots of questions. But one of the things we asked them, oh dang, sorry, I had to the slides first. Hang on, hold on up. So this is my other job, surveillance. So if you look at the dark blue Saskatchewan, Manitoba did not used to be, dark blue is not good on this chart. You look at Manitoba. So a needle on the ground is an issue, and we'll talk about that. But this is a much larger issue for us. And if I think about what keeps me up at night, in this job that I have with public health in this region, this is it. We're 2.5 hours away from Manitoba. Our syphilis outbreak came from there. We're a shared needle away from this now. In 2012, Wawati News did an article where it says Northern Saskatchewan medical officer Halt warned Northern Manitoba that if they didn't do something, they were going to be rivaling Saskatchewan. And so in 2012, I worked with the Sioux Lookout First Nation Health Authority, and we implemented needle exchange programs up there. And so far, so good. Saskatchewan now has mutated veins, or strains of HIV. If you keep a virus long enough in a population, right, it starts mutating. They can't figure out how to treat it. And harm reduction remains on hold. That's the idea of that ideology versus evidence there. Back to what I was saying. 140 of our needle exchange clients we surveyed across the region a couple of years ago, and an extraordinarily high number of them report not sharing their needles. This is what we need. I've never seen this high. We were ecstatic when we saw this. This is what we need. If we want to not have Kenora in the next headline like Saskatchewan, this is what we have to have, because this is how we will get HIV in our population. So how many needles do we give out? That was asked too. Everyone could just... I don't know what number would make people happy. I know this number doesn't. But I'll show you what we've given out over the last 2 years. And this is Kenora only. Needles in is the number we got back. Needle out is the number we gave out. Our return rate in 2014 was 20%. So that's been one of our goals over the last few years, to get more of our needles back. It's sad to see, we're sad to see this. We've had this program since, we think about 1994. I wasn't around then, it was probably written on a sticky note somewhere. We didn't have the internet so much back then. And there wasn't a need for it then. There was a need, for sure. But when oxys became a huge issue is when we saw an exponential increase. And then again when oxys were delisted. We don't want to see this. But we will continue to do this until we get the problem fixed, because we have to. We don't have a choice. Here's the services we provide within the Northwestern Health Unit Harm Reduction Program. Needle exchange program, opioid overdose, we give out naloxone kits to save someone's life if they overdose. If you need one, talk to me after. I don't have them here, but we can get it pretty quick. Safe needle pickup and disposal, and outreach. That bottom picture, those are some of my 4 favorite people. They're incognito way down at the other end. These are 2 public health nurses, Jen and Becky, our health educator, Alex, and our physician, who's new to us, new to Kenora, new to Canada, Dr. Johnny Greck. He'll likely be standing up. If he won't, I'm going to make him. Not yet. Hang on. Pick a game. Jen and Becky started doing outreach out of a backpack because they were finding so many health issues with the clients we were dealing with, and getting them to go to a merge, getting them to go see a doctor, getting them to go see a counselor. We've had a change in our population. We have to go to where people are now. And that's how they started. We were lucky enough to purchase an organizational van that they've kind of hijacked and taken over to drive around and to start doing outreach in different ways to people who can't get to us and can't get to health services. You read, we give out needles like candy. Right? We're throwing them all over the place. We don't. We're regulated healthcare professionals. The Needle Exchange Program is an evidence-based part of healthcare, and we provide it just like we provide everything else. Here's a couple of the other things that we do with probably way more time than we do with needles. Jeff touched on a lot of this, our partnership. So the outreach team have a real unique knowledge set because of the work they do. And they use that at these tables they sit at. When they sit at the tables with the youth, how they can talk about what at-risk youth really need, because they see what happens when those at-risk youth turn into adults. They sit at the risk table with tons of partners. The Lake of the Woods District Hospital is a fantastic partner. Greenhack, we've had staff come up with us for outreach as well. The city is a close partner. The Kenora Needle Action Partnership, we'll talk about that in a minute. And substance use delay. So a lot of these pictures is my staff providing activities, even just for an hour a week, to get people away from where they're, just get them out of that environment, to get them to feel a bit. Maybe it's music, maybe it's art, maybe it's just having a piece of pizza and sitting with somebody who cares. But if we can get people to delay just for a period of time, there was one time there was someone in treatment, waiting to get away to treatment. He was in a home around here, and he was having a bad day. And the nurses had the day off, and they went and picked him up and took him to one of their houses, and they sat there and played guitar with him all day, just to keep him there one more day. We want people to get better. Here are some stats from the outreach van. We're called the Needle Van. But here are some of the other things that we've done. This is just from January 1st to July 13th. That's when we pulled the stats. Someone was asking, do we test people a lot? Yeah, we do. We test people a lot for sexually transmitted infections, bloodborne infections. We would deal with a population that are very high risk. We treat people. We do immunizations. We get people to the appointments they need. We give out naloxone kits. Since Dr. Grech started with us April 5th, through a partnership with the Lake Village District Hospital, who's funding him to come out with us right now, so thank you if you're out there. This is the work he's done so far. He's done 8. So to get into treatment, you have to have a physical done by a physician, which can be really hard. He's done 8 of them so far to get people into addictions treatment. Soon we're going to have 7 people started on treatment for hepatitis C to cure them from hep C. And he has lots of, the broken bones, the skin infections, all the things that he sees. He's drained abscesses, and he does this all in the van. There's a picture of Becky drawing blood off the van, Dr. Grech doing an assessment, lying someone down in the front seat. We just make it work. What are we doing about needles? Properly discarded needles. So we do a few things. We'll pick up needles. So this has been a challenge for us, well, most years. Finding needles, finding where people are putting them is kind of an ongoing issue. This year in particular, it's been really different. We've had a harder time finding where all those places are and keeping up with it. We have a partnership with the city to do that. And we're working very closely with them to stay on top of it. We'll come pick them up. You can call us and we'll come pick up the needles. That was a cleanup we did around town not that long ago. It's Jen and Becky and Andrew. Another partnership with the Lake of the Woods District Hospital. They're about $1,200 each. So the hospital actually purchased them for us at the end of last year so that we can put more up around town. We encourage people, if they are finding needles, and even if they're picking them up on their own, just to let us know. Because if there's places that people are finding needles and we don't know about it, we're like Jeff, we don't monitor social media, so we don't always keep up on where needles are being found. We can put these boxes up. If there's one needle found, we might not, just because they're kind of expensive, but if it's an area where needles are being found more often, we can put these up. We have quite a few left. We get some criticism for this. We provide pickup kits for people who are able to and want to pick up needles. A criticism is often, well, health units shirking their duty and they should have to pick it up because it's their fault that the needles are on the ground. We'll come pick it up. There's not a problem. We'll do that. It might take some time. Like if we're in meetings, the other day I had to leave a meeting to go pick up some needles in the parking lot. It might take us a while to get there, but we will get there. But you can't pick them up yourself. We do the training for this. We provide the containers. I think it comes just down to how you view it. So I row, and oftentimes when they go down on a Saturday morning to row, the rowing dock is covered in garbage. I pick up the garbage. I don't even think about it. I pick up the garbage because it shouldn't be left there. I didn't put it there. Yes, I didn't put it there. But my desire to have a clean-looking community comes before my desire to make some point that I'm leaving it there because I didn't put it there, so there you go. But we're okay with that. It doesn't make a point to us if you call us to pick up a needle, we'll just do it, but we encourage people to pick it up. It gets off the ground quicker, and we can keep our community safe and healthy. If you're interested in getting a pickup kit, again, just come talk to me and we can get you one. I think I'm almost done. Just some other things we do. So the Kenora Needle Action Partnership. So when I did a presentation here in November, a few people stood up at the end and said, what can we do to help? And I didn't know. It's like, wow, I thought of this. But there was a lot of energy around this. A lot of people signed up. We had people from the general public, people, community partners, who wanted to come help. So we had our first meeting in February where we met to figure out what does this group want to do. It's doubled, I think, in size. I sit on it, Jen, one of the nurses, sits on it, Jeff sits on it, someone from the city sits on it, lots of agencies and people I see here are sitting on it as well. And we're working with terms of reference, we have a strategic plan, they're giving us feedback into our resources, they're giving us feedback into what the public are saying, when needles are being found. One of the members, I don't know if he's here, he's not here, anyway, he works downtown at a business, he came to a biz meeting. So Jen had to go present at a biz meeting to talk about how we invest in needles, what's going on, and she barely had to talk. This guy from our group did all the talking. He was like, I used to hate this program, and this is what I know about it now. We got everyone on board. It's fantastic energy on this group, and I'm really looking forward to the work we're going to do over the winter to make things better for next summer. We talk to kids. So someone asked a question about safety in schools. This is where my small piece in that would fall. Knowledge is power, even for kids. Canadian Pediatric Society has a position statement on this that we need to talk to kids about needles on the ground. Typically, if kids get poked by a needle, they're between 5 and 8 years old. It's typically boys. Of course, it's boys. And what happens most often is that they purposefully pick up the needle and poke themselves with it. So they're not like playing and fall on a needle. They pick it up and they purposely play with it. And they poke themselves. So we give presentations. This is the poster that we put up in all the schools. And this is the type of presentations we do. We have an interactive sandbox. We talk to kids at a very early age about how to be safe outside. So they'll dig in the sandbox, they'll pull out a little bottle of sunscreen. Let's talk about the importance of sunscreen. They'll pull a picture of a life jacket. And we incorporate it in. We have a, it's not an actual needle, like in a wrapper kind of thing. We might even just have the wrapper sometimes in a picture of the needle. What do you do if you find this? Don't touch, tell an adult. We have some of our equipment, so like a tourniquet we would put in there, and we tell people even if you see that, that means a needle might be close by, clear the area, don't touch, tell an adult. It's age appropriate, so we don't talk to JKs about crystal meth and how you inject it. On it, we don't. But they get it. You just say, this is sharp, you can hurt yourself. Don't touch, and that's usually where that ends. As kids get a little bit older, by about grade 6, they might be babysitting other kids. We change the message a little bit about how to get other kids away from there. We're also redoing some of our resources. The 2 pictures on the right-hand side, the longer panels, is a resource we're doing for parents on how to talk to your kids about this. So if we do go into classrooms and do presentations, we want the kids to come home with a resource for the parents to know this is what we talked to your kid about today, and here's how you can reinforce that message if you want to. Ooh, there you go. So I didn't put my cell number on it, but if you want it, you can come get it from me. And that's my email there, and I look forward to the questions, so thank you for your time.
Thanks, Jillian. Our next co-presenters are Henry Wall, the CAO for the Kenora District Service Board, and Patty Fairfield, the Executive Director of the Meet Cheat Friendship Center. And just so everybody knows, at the end of this presentation, we'll take a 5-7 minute break so everybody can stretch, get up and move around, or use the washroom if you need to. So Henry Wall is the Chief Administrative Officer of the Kenora District Service Board. In his role, Henry brings an innovative approach to the delivery of programs and services administered through the KDSB, such as Ontario Works community housing, early years programming, and emergency medical services and land ambulance. The KDSB serves approximately 65,000 individuals across 9 municipalities and a vast area of unincorporated territories. Henry believes that complex needs and challenges often call for comprehensive and integrated solutions in order to diversely support the district's individuals and families. Patty Fairfield was born and raised in Kenora. She has worked at the Friendship Center since 2002 and has been the executive director since 2013. She oversees 24 programs at the center that cover everything from justice, employment training, education, health and social services. For her employment, she sits on many committees. She sits as a volunteer board member for both Sunset Area Victim Crisis Assistance and Referral Service and the Adult Learning Line. Welcome, Henry and Patty.
Perfect, it worked, great. Thank you very much for coming out tonight. I think these sessions are really important to our communities in that it gives us an opportunity to have some honest discussion and sometimes talk about things that may not feel very comfortable to talk about. And so in my presentation this evening to you, I want to kind of go look over very briefly in terms of who the KDSB is, but also in terms of what are we seeing in terms of changes in the community, and also what are some of the solutions that we're proposing and wanting to move forward with so that we can do a better job at supporting individuals in our communities that really are struggling. So look at what the KDSB, our geography that we're mandated to cover is just over 400,000 square kilometers. So you can fit almost a big chunk of Europe into this region. It's massive. We don't directly deliver services in First Nation communities, however, we do deliver land ambulance EMS services to about 18 First Nation communities. We are also expanding because of the complexities and the fact that a number of municipalities are also hub community service communities, that we feel it's really important that we have partnerships with First Nation communities so that we can do a better job at supporting families and youth and seniors across this entire region. And which is why we recently have MOUs with our Chiefs Advisory as an example to work on tough issues such as addictions, mental health, how that relates to housing, but also homelessness. And same with our MOU with the Anishinaabe Nation, that when we talk about homelessness, we can't address homelessness just simply in the city of Kenora. This has to be a regional approach and has to involve all communities. A little bit about our board of directors in terms of how's our governance structure. It's like there's quite a few questions on that as well. We have a board of directors that's made up of 13 members, and they're all elected. Our 9 municipalities that we represent each have an elected official to our board. We also have 4 corporate territory members who are directly elected to our board. So our board of directors is made up of community members, elected community members. And so our organization is run by communities for communities. This isn't a budget presentation, I promise you that, but the reason I want to talk about this, why I have this slide up, and you might have to put on a bit of your Superman goggles to see it, is when it comes to addressing issues and challenges, it's going to take resources. It cannot be done just simply by talking about it and wishing that things would be better. It's going to take some real meaningful resources. And annually, our operating budget is just over $56 million. But a big portion of that comes from our local municipalities and unincorporated territories. So that's why I want to talk about this particular slide. We oversee early learning and care. This means child care. So if you have a child or grandchild or niece or nephew that is in the licensed child care space in Kenora, chances are that we're funding that space. And the reason that child care space is run on a daily basis between 40 and 50, sometimes more than that, dollars a day, is because with us and through the Ministry of Education, we provide quite a bit of funding to organizations in this community so that we can have affordable child care. And we also oversee the early on centers, which we contracts, or a number of organizations in this community to do that. We oversee Ontario Works, which includes social assistance, a number of employment programs, pre-employment training, and such life skills stabilization training as well. And then asset management, this is housing. It includes housing for seniors. It includes affordable housing. It also includes community housing. And organizations such as Kenora Municipal Nonprofit Housing Corporation, as an example, we fund that as well. And on an annual basis, as an example, we provide the nonprofit with about $1.3 million a year, so that rents for the families there and for the seniors there, that they can actually be affordable and that can actually be sustainable. And so overall across the region in our portfolio, we have just around 1,300 housing units. And the last part is land ambulance senior services. So we deliver EMS across the region. And what I want to talk about is in terms of the cost that, the increasing cost that we're seeing. So if we look at 2016, that year was the first year that the cost to run EMS, or the resources that were allocated to land ambulance, to lights and sirens, were more than we actually spend on housing. And we fast forward to 2019, we're anticipating that we'll be spending about $3.6 million more on EMS than we are on housing. And so what this means is that we do have a limited amount of resources. Our communities have a limited amount of resources through property taxation to afford this. And so if we're investing all our resources to responding to emergencies, the resources are coming from that, which actually makes a difference in getting people off the streets, or actually preventing the calls in the first place. And so this is why we're putting so much effort into prevention. Because lights and sirens is an incredibly expensive way to address our community challenges. And also why last year here in the city of Kenora, with the approval from the Minister of Health, we put an additional EMS crew. So Kenora has a population of about 60,000 this summer. It's more. We now have 3 EMS crews day and night. I don't believe there's another community in Ontario that has that kind of a ratio. But also speaks to some of the challenges that we're seeing in this community. Health equity only exists when everybody in our society has the same opportunity to reach their maximum potential. But I think I'd like to amend this and say that I think health equity can only exist when we all have equal opportunity to accessing and reaching our potential. And that is not the case for too many of the families and individuals living in our communities. The youth in our district are 8 times more likely to commit suicide than anywhere else in Ontario. And we look at in terms of poverty rates, we have the second highest poverty rate in Ontario when we look at by federal electoral districts. We're number 2 when it comes to children living in poverty. And when we look at the number of families, low-income families that have children, we rank 7th in the entire country. So I can tell you that makes a huge difference in our communities where we have families who are barely making it by, that are just on the cusp of losing, whether it's a housing situation or whatever that might be. When there's changes, it pushes more people out. And as our housing market tightens, more and more families are pushed to the edge. And we're seeing that with the number of individuals that experience homelessness, or the number of families that are having to look at other options. And I can tell you, when families live in poverty, it comes with all sorts of other things. And it also happens that we have one of the fastest growing populations in Ontario as well, our district. Between 2011 and 2016, Census Canada estimated it was about just shy of 14%. It's not quite that. Our census is a bit, there's some estimation to that Census Canada does. And there's a number of communities that don't participate in the census division. So it's very likely that this number is even understated in terms of the growth. And also we look at in terms of what is the change in household. What we're predicting, so this is looking at data that we had in 2011 and working with the Ministry of Municipal Affairs and Housing, the data they have, and other organizations in terms of looking at that data set. Between 2011 and 2020, we're estimating, projecting that when it comes to family households, that we'll see about 26% growth in family households. We'll actually see a 45% increase in lone parent households. So when we look at, and this is on the other side, this is households with number of children. So households with 0 children, with 12% increase over that period. But then you look a little further, so households with 3 or more children, we're estimating that's going to grow by 59%. So we have substantial increase in lone parent households with more than 3 children. And so you can see why it's so incredibly important that we actually have access, that we create access for families to affordable childcare. And for this reason too, and I think here in the city, the KDPs, especially of recent research, is known very more for homelessness. That's all we focus on. It's not, it's only a small part of what we do. Our main focus is to prevent it in the first place. And why we're starting last year, we're in partnership with the Ministry of Education in the province of Ontario, we're creating more than 150 new childcare spaces. Just what we do know is that when families are looking to get by, you need to have access to childcare. Especially if you have a single mom or dad who's trying to make ends meet, they need to have access to affordable childcare. Not just that, they just have access to childcare, period. It's also very important we look at housing. What kind of housing are we building in this community? And I think in the city of Kenora, any housing at this point is good housing. That's how tight the housing market is in this community. And it's like that in other communities in our district as well. And so it makes it harder. This is where then we see other aspects, whether it's mental health, whether it's addictions, all those things follow. And so we do need to make sure that life is affordable for families. That should be the goal as well as a community for us. When we look at, this is in 2017, we look at the rate of hospitalization for mental health and behavioral disorders. We do it by age. We compare ourselves with the oranges Ontario. And I apologize that the writing it's a bit small. The blue is the District of Kenora, and the orange is Ontario. So when you see that the first line is youth ages 15 to 24, we don't just exceed the rate for Ontario, we blow it right out of the freaking water. These are young people. This is our future as a community. And yet, they're struggling. And they're representing at our hospitals at a rate that doesn't exist anywhere else in Ontario. And this is why the work that many of you are involved in terms of getting youth programming to this community, those are involved in the youth hub development, with our Chiefs Advisory, keep up the work, because that's what we need to do to start curbing these rates. This is our call volume over the last, between 2014 and 2018 with regards to 911. In 2014, as an example, we had just under 4,100 calls, 911 calls for Kenora base here. 4 years later, it was almost 5,400 calls that we've seen. It's a steady growth, and I can tell you some of the questions that we got that were emailed to us is that there's a belief by a number of individuals that homelessness didn't exist until the service hub opened 6 months ago. I can tell you that's wrong. And I can also tell you that the challenges that we're seeing today, that we're facing today, have been in the making for a long time. It's just they're a bit more hidden than they are today. They're much more open today. But based on our call volume, so let's keep in mind too, Kenora's population is 16,000. And in 2014, we had over 4,000 911 calls to this community. That doesn't even make sense. So this is where, as a community, we need to start getting together in terms of how do we support our community members who are struggling. The other thing that I had our staff do is I want to look at in terms of just, so this includes kind of some of the surrounding regions as well around Kenora. I just want to know the city of Kenora itself, because it's partly why we're all here today. What does that look like? Well, when we look at call volume just for the city of Kenora, we kind of do a bit of a boundary around the community. Our call volume from last year to this year in the first 6 months is up 40%. And the other part too that I want to make clear as well, and this is from some of the questions that we received, is these calls aren't happening around the service hub. It's not like that's a hot spot. They're happening throughout the entire community. So if you want to start dotting this, Kenora is just a blob of red. So it's not just one area. This is throughout our entire community. And I can tell you, this is not sustainable. We have staff that are doing an amazing job. We have incredible paramedics here. But this is unsustainable. And it's also not a solution. Because all we're doing is we're just transporting patients to the hospital to be released and transported again. And so why we've been pushing supportive housing as much as we have. And that is one way to get ahead of this. I also want to show you this graph, and I had a bit of a challenge with this graph in that the red line represents patients that First Nation patients, and the blue is non-First Nation patients. And I wasn't sure if I should share this or present it this way. And a mentor of mine, who was also chief for one of the area commuters, I called the chief and said, "What should I do?" And she asked, "Well, is it the truth?" I said, "It is." And she's like, "Well, then there's your answer." I think that's what tonight is about, is talking honestly about what's going on in our communities. And so this graph shows when we break down that call volume for the last 6 months in this community, having age on the far side, as you can see, our challenge that we're seeing in this community isn't just an Indigenous issue. This is a community issue. It is almost equal up until we get to about age 50. So we have Indigenous and non-Indigenous people struggling in this community. And so some of the questions I got is that this isn't just an Indigenous issue. So I want to make that quite clear, and the data speaks to that too. But what should be very concerning is that why is there such a drastic drop-off after the age of 54 to Indigenous people? I think those are some questions that we should be asking is, why is that? Is it that elders aren't accessing our healthcare system? Or is it that we have Indigenous people dying prematurely? I don't know the answers to that, but I think certainly as communities we start getting to the bottom of that, and also why we have community partners. We have the All Nations Health Partners who've been working for a very long time to make sure that we have a healthcare system that supports everyone in our community, that everyone feels like you be part of and have a stake in it, that it's not just perceived to be just for one kind of people, it's going to be for everyone. And also when we look at this, and back in 2018, when the province of Ontario put on the oversight for the early on centers to the KDSB, we wanted to make sure that we were actually meeting the needs of families. And so we spent quite a bit of time before the transfer date to talk to families, survey families. And we got a lot of information back, a lot of feedback. But what we found when we looked at the feedback in detail, we heard a lot from non-Indigenous families. We heard almost nothing from Indigenous families. And so we had to go back to the drawing board and think, why is it in a community that is almost half and half Indigenous and not, why is it that we are getting such a low rate of response in that matter? And so working through a number of our Indigenous partners through the Friendship Center, we were able to reach those families. And you know what we heard back is that there are many Indigenous families that don't feel accepted in a lot of the programs and services, or don't feel safe accessing them. And so we talk about community safety. This goes both ways. This is just based on some of the questions that were forwarded to us, is that we need to make sure that all families in our communities feel safe. And I think this is where we need to understand what mental health and addictions are. We need to understand what is driving homelessness, and that homeless people aren't scary people. Is by doing that, fear is starting to take over, and you can feel it. And then we do all sorts of crazy things as communities. We start shutting people out. So that's something I want to leave with you in terms of, I think, as we move forward, how to ensure that every member in our community feels like this is a community that they feel accepted in, they feel comfortable in, and this is a community they want to raise their children in. So the other stat I want to show to you as well, in terms of when it comes to intoxication calls, our call is almost 300%, just over 300% in the first 6 months of the last year. This is why addiction treatment services are so important to have in this community. Why we need to, as communities, as a community, get together and say we need those supports here. It's not good enough that they're in Winnipeg, Thunder Bay, because that's not acceptable for our community members. We need to have the support here. And also, when we look at it in terms of behavioral and psychiatric type calls, it's more than double this year versus last year. And again, when we look at the data, where the call's happening, I can tell you it wasn't the shelter, it wasn't the service hub that's creating this challenge. And also why we can start looking at it, when we look at individuals that we sometimes refer to as not frequent flyers, but in terms of individuals that we access the system much more than the normal population. So we did that too. We looked at our call volume in the last 6 months, and we had 18 individuals in Kenora who were brought to the ER in the back of an ambulance 331 times in the last 6 months alone. I can tell you the cost for this would have provided them with housing for a year, all 18 individuals. And so, in looking at this, it just makes good business sense to support people and to look at investing in housing that has supports along with it as well. Sorry, Dan, I almost drank your water.
That's okay. It's vodka.
Ease the tension. The other thing I want to share with you as well is that you're not alone in this. So we look at, based on these calls for services and EMS calls for services based on population, I can tell you driving to look at facing similar challenge to this community. And so it's important that as communities we share knowledge and we get together to solve this as well, because you're not alone in this. Other communities are struggling with this as well, and the solutions there are a bit different, but also the same. And so this is, I do want to share a couple examples that we've been able to try and do in other communities that are effective. This is our overall calling for EMS for the last, well, since 1996. The blue line is non-urgent calls, and the pink line is urgent calls. As you can see, our calls for urgent calls, it's almost like it's on a jet plane taken off, and there's no sign that that is actually occurring. And so when we meet with our staff and sort of talk us, this is why we start looking upstream in terms of how can we prevent this from happening. Because I can tell you financially this is not sustainable, not for our communities nor for the province of Ontario. When we talk about housing, I think that's another piece. When we look at housing and the need for housing, so the numbers I'll give you, these are families that are on our housing wait list who have qualified because of their income. This does not speak to families who have jobs, who have income, but don't have access to housing. So this only speaks to the number of families that, from an income perspective, are in our housing wait list. And as of the end of 2018, we had almost 1,100 families on our housing wait list waiting for housing. In Kenora alone, there's 513 families waiting for housing. So we could build 513 housing units today and just address the current need, let alone how it's growing, and it is. So we look at, say, 2011, we had 382 households on our wait list across the district. Fast forward 2018, we're at 1,091 families. And this is housing across the spectrum. We have over 100 seniors waiting for housing, affordable housing, so seniors who cannot afford their current situation. And we know that if we don't do something, their quality of life will deteriorate. But we also have families. And we have singles who are looking for housing and who are doing all sorts of things to maintain a couch or to maintain a room somewhere. And that along brings other challenges as well. It's not impossible. There's a number of housing projects that are in the works. I know we've talked about and dreamed about housing for a long time in this community, but yet when you look around, there's not many sticks that are popping out of the ground for housing. So I'll share a few examples of what's in the works. When we did our homelessness immigration study in 2018, across the region, we found in our 9 municipalities, so just in municipalities, we had 393 individuals who were homeless, truly homeless. So they weren't necessarily just precariously housed. These were individuals who were homeless in our communities. And in Kenora, over 200. So again, I can tell you, it was not the service hub that's attracted all people from all over the place. That being homeless in Kenora is better than elsewhere. It was just more than it has been now. And so in part, when we look at the service hub has capacity of 46 individuals, yet we have over 200. It is a significant number. The other part that we found too is through that study is that about 18% of the individuals at that time when we did the study were in jail, here in the Kenora jail. So not an appropriate way to host individuals who are homeless. And what we estimated, working with the Attorney General's office, that Ontario spent this is in 2018, about $5.6 million housing homeless people in Kenora jail. and which is why Ontario is moving quite quickly and with purpose to look at the Justice Center for Kenora and look at how can we actually change this so that this is not the only solution, how we address people who are living in poverty, who are struggling and need a place, who just need a place for supports. I also want to share this graph as well. So this graph is 911 calls across the region for the entire year of 2017 by age demographics. And I've broken it down in two parts. Male is the orange and blue is the female. And so we look at that, so we have age 0 on the far, so it would be on your left. This graph should make us angry. That the highest, the demographic that ended up in the back of an ambulance the most were our girls between the ages of 11 and 15. And not just by a little bit, we're talking about a long shot. And that doesn't really change until we get after the age of 21. So our youth are struggling, and they're in trouble. And so the question is, what are we going to do about that as a community? In particular, young girls. What are we doing to support our young girls in this? And why is it that they are leading the way, that they're the highest demographic that's ending up in the back of our ambulances? What is some of the response? Now that I give you a lot of doom and gloom, there's hope too. Absolutely there is. And there's a lot of really positive initiatives that are in the works. And I know there's some terrible announcement, a hard announcement that was made earlier on Monday, and we'll talk about that as well. But also in terms of some of the other projects that are in the works. In partnership with Ontario Aboriginal Housing Services and through funding from Ontario, from the Government of Ontario, $4.5 million, we're going to move forward in developing a 20-unit supportive housing program as well as a 10-unit group home. Sorry. And this is happening. We have the land, it's rezoned, we're working with the city on the water and sewer connection. This project will be open in the next 15 months. Knock on wood. So this is going to happen. And we've heard from a number of you and a number of people in the community saying, if the land, could the land support more units? And it can, so why aren't you doing 30? So that's something that we're going to look at, we're looking into in terms of being able to finance it and so forth so that we can actually, we need more than just 20. But this project is happening. And it works. So this type of supportive housing works. We tried it in Lookout. Next month they will have operated for a year, and I can tell you it makes a difference. And so I want to show this to you if it works.
What is home?
What is home? I think home is where you choose it to be. Home is where you're safe. Home is where you have support.
Home, where you're safe, you feel loved, you're appreciated.
You can just relax and breathe and just have your own time, your own space. Knowing that you're going to be okay, being able to reach out to other people.
Home is where you choose that to be, and they've never had that option to call a place a home. Our tenants have never had that opportunity, a lot of them.
What is home to you?
Stability.
Having a home is probably one of the most important things in a person's life.
It's necessities, but some people just take it for granted, because it's always been there.
It's something that everybody deserves and not everybody has.
Silicat's had a negative housing situation since I came to Silicate in 1975 or 76.
The issue of homelessness, the issues of addictions, and the issues of mental health. That is the largest percentage that we deal with on a daily basis.
All communities have these issues. We continue doing the same thing over and over.
People may not understand, like, when women choose to be homeless.
It's very difficult to get a job when you sleep in a derelict car at night. It's very difficult to get a job when you don't have a watch.
You can't work on anything. The trauma, the addictions.
The housing first model, I mean, that's really what needs to be in place first and foremost before we can address any further concerns.
The supportive housing unit here in Silicote opened on the 15th of August 2018.
There are 20 units, a wing on each side with the kind of hub and the kitchen in the middle. Supportive housing gives that basic need to every individual, any individual that needs that roof over their head. Safe and affordable housing with supports. Bringing in the supports on site to ensure that people can move forward in whatever that means for them.
At the end of the day, this money is taxpayers' money, and it's much more efficient to provide someone with housing than to leave them on the street and having them dealt with in a reactive manner.
There's safety, there's companionship, there's friendships. It feels like a big family.
It's a relief to have. It's a blessing.
We're providing people with a new start.
Giving them a chance to have a better life is really what it's about.
You're only as strong as your most vulnerable in your community.
I don't think I've ever seen the agencies in Silicote work together as much as they have.
Basically, anything specific to a tenant's needs, supports will come in.
We have already seen great successes with people, getting away from addictions and becoming functioning members of society.
Just having the security of knowing I can come to my home.
To see the smiles and the pride, it's an absolute pleasure and an honor to be a part of a project. Sorry, such as this.
And it takes a lot of partnerships to make it work as well. And does it work? Absolutely. So this slide is what we did is we worked with the OPP. We looked at, in terms of calls for services for the 20 residents that moved in. What was it like 4 months prior to move-in date? What was it like 4 months after move-in date? And what we found generally a significant decrease in the number of times police were responding to these individuals. In fact, over that period of time, there's a reduction of 188 calls for services. And so we're now almost a year into this, and the estimate is that there's a reduction of 564 calls for these 20 individuals. That the cost savings to the municipality between $200,000 and $300,000 a year. So we translate that in terms of what the median assessment for a family home in Kenora is and your tax rate. This is equal to 10 homes in terms of the property taxes you pay per year. So it pays to support people and meet them where they're at. And so why we're going to know it works and why we're not going to stop until we have these programs here in Kenora as well. And this goes along, as I mentioned, with youth that are aging out of care who are struggling. They're not criminals, they're not involved in the law yet. But we know that if we don't, that is a very likely path that many might face. And so this is where, in working with a number of you, a number of community organizations, and Ontario Aboriginal Housing Services and the province of Ontario, that we're going to do a 10-unit group home as well. The tenders will close for a 28-unit supportive housing program designed to support individuals who need to be taken out of the justice system, that are in the justice system because they have no other place and they're struggling. And so this project, this construction will begin this summer on this. This is 28 units. It took a long time to get here. We had a number of rezoning challenges that we had to jump through and so forth, but this is moving forward. We're excited to say that and know that come next year, this is going to be open. So we're looking at adding 58 new housing units. It's not going to meet doesn't address the entire need, but it's on the way there. And if we do this every year, we're going to start catching up. That's kind of what it's going to look like. And also, it's very exciting with us that we're able to partner with CMHA in developing a safe vet program in 2A. So for individuals that end up in contact with the police, instead of taking them to BR or to jail or to the service hub, they get the proper supports here. And so very excited. This stuff works, and we're seeing it already in the time that it's operational. And I will say that it is very challenging. So all the communities that we support, getting stuff built is very challenging in Kenora, more so than our other communities. And a lot of it is, maybe it's education, maybe it's public perception, but we find that there's a good amount of opposition when we look at any kind of housing bill. So it certainly makes it more difficult. And I'm hoping that through conversations like this tonight, that we can start dispelling some of the myths, some of the fears around this, and that as a community we can have more of this happen as well, more of these forums, but also we have housing happen, period. It was incredibly challenging. Probably one of the toughest decisions that I've been part of to temporarily close the shelter in 2 weeks so we can regroup to ensure that when individuals access the shelter, the service hub, that they're safe, that they're protected, but also that we're not just simply having people survive, but we're actually setting people up to thrive in this community. And there's never a good time for that. And which is why having it closed for up to 45 days, it's a short time period, and why we're getting our act together to make sure that we're ready, and that when it opens up, that we're prepared for how this community has changed when we first started the planning of this. And so certainly I'm sure there'll be lots of questions on that, and I welcome any question on it as well. So with that, thank you very much for your attention. I'll hand it over to Patty. Rich.
Good evening, everyone. Part of the panel, as most people know. However, with all the talk in the community, what I've seen in the media, comments that are made, a lot of it has been aimed towards the service hub shelter. So I really felt it was important that I was here to speak. So I'm grateful and thankful that I was able to do this this morning and now this evening. It's been a long last couple of days. I spent a lot of time yesterday writing out what I wanted to say. I wanted to make sure that I covered everything that I thought was important for the community to know, and also reading through all of the questions that were sent in, trying to address a lot of the things that were brought up pertaining to the service hub. So, in writing things out, what I tend to do is tend to look at my notes a lot, so I just wanted to give you the heads up. I do apologize, but I want to make sure that I cover everything that I wanted to say. So I want to give you a little bit of background about the Friendship Center. So the doors of the first Friendship Center opened in Canada in 1958, as Aboriginal people began moving from reserve to urban areas. As Aboriginal people relocated, they were faced with many problems in receiving services due to cultural differences, bureaucracy, and the barriers of language and systemic prejudice. Friendship centers began in order to assist Aboriginal people with their adjustment and integration as they migrated into the urban environment. The Friendship Center movement is the country's most significant off-reserve Aboriginal service delivery infrastructure. For over half a century, Friendship Centers have helped urban Aboriginal people access the vital services they need to succeed in urban settings across Canada. Friendship Centers understand the challenges facing our communities, and their unique wraparound service delivery model ensures we are well equipped to tackle them. Across the country, Friendship Centers provide culturally appropriate services for Aboriginal peoples living in urban centers and have become a place for Aboriginal and non-Aboriginal people to come together, to share traditions and to learn from one another. The main objective for all Friendship Centers is to improve the quality of life for the urban Aboriginal people. The main target groups of each Friendship Center are the urban Aboriginal population, however, we never turn anybody away. And it includes all age groups. Friendship centers act as a support system to the community by providing programs that provide essential services, which will assist them in contributing to the economy. These services are aimed at promoting the physical, emotional, spiritual, and cultural well-being of all Aboriginal people. Nichi is the Ojibwe word for close friend or brother. The Nichi Friendship Center was incorporated in May of 1976 and is managed by a board of directors, which is elected at the annual general meeting and served for a period of 3 years. The executive director, HR manager, executive assistant, finance officer, and receptionist comprise the core staff. The director is responsible to the board of directors, which consists of 6 members with very diverse backgrounds. And the other staff are immediately responsible to the HR manager, excluding Bell residency workers and hub workers, because they are responsible to the manager. There are 118 Friendship Centers across Canada, and there are 29 in Ontario. Every Friendship Center is different in what they offer. The Nichi Friendship Center is fortunate in that it has 23 programs covering everything from health, justice, education, employment training, and social services. We have programs from pre-birth to the elderly and for all abilities. We have an Indigenous Healthy Babies program, Aboriginal Family Support, Early On, the Ojibwe Children's Program, Indigenous Children's Wellness Program, Wasanaban Youth Program, Youth Life Promotion, Indigenous Healing and Wellness, Apaxuan Employment and Training, the Alternative Secondary School Program, the Indigenous Community Justice, Urban Aboriginal Healthy Living, Lifelong Care, the Service Hub Emergency Shelter, Criminal Court Worker and Family Court Worker that work out of the Kenora Courthouse, Drug Education and Living Worker, Native Inmate Liaison Officer that work out of the Kenora Jail, the Kijay Worker, which is I'm a Kind Man, the Cultural Resource, Bail Supervision Verification Program, Bail Residency, and the Community-Based Sense of Home Research Project. Our vision is to improve the quality of life for Aboriginal people living in an urban environment by supporting self-determined activities which encourage equal access to and participation in Canadian society and which respects Aboriginal cultural distinctiveness. As a Friendship Center, we work very hard to build partnerships wherever we can to ensure that our community members, our clients' needs are met. Partnerships are key to building a community network of services that do not overlap and can be easily accessed. It is important to myself and the Board of Directors that the Friendship Center's staff have a seat at various committees in town. It is mandatory for all staff to sit on at least one committee that is relevant to their position. This is not only beneficial to our Friendship Center, but to the community as a whole, as it assures that people are aware of the vast amount of programs we offer and make the referrals that are needed. As a Friendship Center, we do not enable, we empower people. We provide the knowledge, skills, and tools that are needed so that they may become active participants in the economy. And for more information on the Friendship Center, you can check out our website or our Facebook page. So, getting to the reason why, all the discussion about the Service Hub, I do want to acknowledge and add that we have and continue to take the concerns of the community very seriously. Towards addressing and resolving these concerns, we have been working with our partners on solutions towards mitigating the issues and challenges facing the shelter, its clientele, and the community. We meet bi-weekly with representatives of Knox Church, the OPP, the city, and KDSB to discuss concerns, issues, and solutions. As people are likely aware, when the work towards creating the shelter began in 2015, there was a very different clientele with different issues, needs, and requirements. Within the last 18 months, methods come into Kenora in a prevalent way, which plays a large factor in the issues and concerns expressed by the community. Many cities and towns within Canada are also struggling to address the issues and concerns brought about by the use of this drug, and Kenora is no different. The shelter cannot control the availability or use of this drug, but can only try to manage the outcomes of its use amongst Kenora's most vulnerable. Unfortunately, when planning for the shelter, none of the parties involved could foresee the drug's effects or outcomes on the shelter's clientele and the larger community. With that being said, I am not making excuses or making a point that the issues and concerns expressed by the community is part of a larger issue facing Kenora and the community as a whole. And this larger issue must be addressed and worked on by the community together. The shelter is but a symptom, not the cause of this larger issue. As a community, we can work towards providing services to those most vulnerable to address the addiction and mental health issues Kenora is now facing. When we moved out of the health unit into their new space in Knox, It was still under construction. However, we had to make it work as we need to provide a space so we could house people out of the cold and have a place for them to sleep. Things that were not foreseen have resulted in further barriers. For example, the industrial washers breaking down, so we've had to use small residential machines, which are being used in the program lounge room area, and they're continually going, as you can imagine. We have a large amount of things like towels, bedding, blankets, nightwear, and kitchen items. The TV was just connected prior to the July long weekend with no cable service installed as of yet, so staff have been using their own personal Netflix accounts to provide our patrons with something to watch. We also bought several board games, cards, and crib boards to help prevent boredom, which we know can result in negative behavior. The shelter has been working to the best of its ability with the resources that are currently available to operate and meet the needs of the clientele in a safe and effective manner. However, due to many factors, the shelter has not been able to provide all of the services we had intended as of present. The shelter is actively working on resolving these shortfalls in services, and it is hoped that the intended hub services will begin and will soon address the issues and concerns that have been expressed. It is important to note that a meeting was scheduled with some service providers that we felt were the most in need right away. We were fortunate that WINAC's Executive Director, Anita Cameron, offered to assist us with this and offered Lucille Michaud, which is one of her employees, to facilitate it. However, from this meeting came several questions, including safety, layout of the facility, and the space that was going to be provided. Due to the issues mentioned regarding not having space completed that would be the program room area, we have been unable to provide the programming as of yet. The tour of the facility did happen, and most of those organizations who were at the meeting did attend. At the table were organizations that mainly dealt with mental health, and addictions, along with law enforcement. We do know that quite a few of our patrons do have workers already in the community. I would like to point out that we have provided some of our programs and services to the patrons, which have been in-house at the shelter, our main facility, and our court workers at the courthouse. While we have not scheduled actual programming at the shelter due to not having the space at this time, it is important to note we have been open to other service providers coming in to meet with their clients. We have had the OPP stop by quite regularly, and that's not just because they've been called because there's an emergency, because they have come by just to have coffee and chat with the patrons and the staff. We've also had staff from Kenora Chiefs Advisory come by periodically to volunteer their time, and the health unit staff come by regularly. We have reached out to the Ontario Federation of Indigenous Friendship Centres in regards to the issues we are facing around meth. And we are hoping to get information on how we as a friendship center can work with those addicted to this drug, and also what tools can we get so that we can start working on prevention. Right now we are constantly dealing in crisis mode, but we need to be able to start looking at prevention, or we will never see a change, and in fact it will only get worse. We have a higher volume of people coming in for food that are not residing within the shelter, but the need is there. We serve anywhere from 50 to 70 people, including families. We have a cook and a shelter patron who volunteers his time in the kitchen to prepare all meals. We have limited volunteers, however, and it must be noted that the kitchen is not really conducive to more than 4 people to fit comfortably. So to dispel some of the rumors that we have heard, we do have rules at the shelter, and when they are not adhered to, there are repercussions. Depending on the severity, it can be a verbal warning, it can be an eviction for a few hours, up to 24 hours, or it could be putting a ban in place, and that could be for any amount of time. It is always explained to the individual why their behavior is unacceptable and the ways that we'd like to see them improve. When someone is evicted or banned, we do not provide food or beverages to them during this time. We do not have a waiting list to get in, and in fact, we have not been in full capacity in at least a few months. We average about 34 to 34 people a night. And I would say that most of our locals who stay at the shelter, most of them stay at the shelter are local. And I am not sure why anyone would want to come to Kenora just to stay at our shelter. I don't think we're the Carlton Ritzes of shelters. Lots of communities have shelters that provide overnight accommodations as well as food. I would say most of our patrons are not new, but rather come from Lila's Block. No one knows for sure how many people were staying in that building, but I have heard upwards to around 70 people. And when they were staying there, they didn't need to come out, so it's not on our basis to the extent that we are seeing it now. Our staff continually talk to the patrons about respecting private property, about not loitering or littering on public and private property. We do not allow sleeping during the day, due to the following, that we need to make sure that the bunk areas are cleaned out because we have to make sure that, keeping control of bed bug infestation. Also for health and safety reasons. Due to cleaning in the day, doing laundry and other items, the staff are unable to monitor the bunk areas, so the doors are closed and locked during the day. The lounge area is not that large and was having to accommodate with doing the laundry and those types of things in there as well. And people there watching TV, they're not allowed to sleep in that room either. Because of this, we see many people, as people have talked about, sleeping outside, especially in the Knox area, because we know that people on drugs, especially meth, they can be up for days. So when they need to sleep, it could be any time. So that's why we tend to see that. We have an intake worker at the door that checks all bags and gets individuals to empty out their pockets. Bags of any kind, including purses, are not allowed past the intake area. We also check for weapons, as they are not allowed inside the facility at all. We had hired one Northwest Security 3 months ago in hopes that their presence would deter negative behavior inside the shelter, and today is actually their last day, as we feel the money would be better spent to hire additional staff that could provide more supports that we know that are needed. Our staff currently have been working, and the security company was working from 6 at night till 6 in the morning. We currently have 3 8-hour shifts for our staff, Monday to Friday from 7 to 3, 3 to 11, and 11 to 7. We have one worker that works on the intake, which is when you come in the door, and then we have 2 doing cleaning, washroom, doing the laundry, all of those types of things. And on the weekends, we have 2 12-hour shifts with 2 staff only. And we realize that we really need more staff, definitely on the weekends, because this is the time we see most people. It is important that I state that the Friendship Center was not part of the decision making regarding closing the shelter for 45 days, and I was only made aware of this decision 2 hours before the public announcement was made. I was also not made aware of where the media release was going to be taking place, or I would have attended. So, steps forward. We have hired a comprehensive management team who have been working diligently on staff training, enforcement of rules, intake process, along with staff and patron collaboration. What we were and have been working towards, daily job boards, restorative justice practices, so if somebody causes damage inside the shelter, they will repair it. Life skills, scheduled programming with external partners and our internal programs, as well as researching other shelters to figure out what they're doing with their shelters and the crisis that they're seeing in their communities, and being able to format some of their best practices to what's going to work in our community. Our staff have been quite resilient and work in an environment that is not always pleasant. And when I say this, I do not necessarily mean that they are being verbally assaulted or mistreated, but more along the lines that there are individuals who should not be in the shelter but should be in a healthcare facility due to their medical needs. The shelter is not a treatment center or a medical facility. However, many of our vulnerable people, which include seniors, young people coming out of care, and young girls have no place to go. We are not a judge and jury, and we never take this kind of approach. Everyone has a story to tell, and some are much worse than others. I truly believe that no one sets out in life to become addicted to alcohol or to drugs. And for some, life's path can lead them down a very dark and lonely path. As human beings, we all need hope, love, and compassion. And let's face it, there are those that have never been given any breaks in life to have hope, or have even experienced what it is truly like to be loved, and have someone who truly cares about them whether they live or die. I would say most people in this room, including myself, either know someone or have a loved one who suffers from an addiction. We as a Friendship Center have made a commitment to the people, and despite the fact that the doors will be closed for 45 days at the shelter, we will continue to carry through with our commitment. Our shelter workers will be doing outreach out on the streets during this time to provide food such as sandwiches and water, making referrals to services, and ensuring people are all right and as safe as they possibly can be living on the streets. We have some individuals that we know will not survive being on the streets, so we are actively working on getting them placed to ensure this does not happen. I will also be working very closely with our partners and management team on whatever needs to be put in place when the shelter reopens. I thank you for listening, and my hope is as a community we can work together. Thank you.
Thank you, Henry and Patty. We'll take a 5-minute break and then we'll have our final presentation. The city's senior leadership team and oversees economic development, Northwest Business Center, planning and building. Adam has a BA in political science from Brock University and a Master of Public Administration degree from Queen's University. Welcome, Adam.
Well, thank you everyone for coming to this second community safety forum that we are having here today. I will try to be quick. I did tell Jeff to shorten his presentation, which he did do, but that's fine. Anyways, just to give you everyone a brief overview of what I'll be speaking to today. I'll first start by talking about the relationship between the City of Kenora and community safety. I'll look at some of the recent initiatives we've pursued to try to drive community safety within the city. And then also next steps. So talking about some of the action planning that we have envisioned over the short term. Then finally, I'd like to end on a positive note. So kind of getting out of the shroud of negativity, which certainly I think we've perceived in town, and talking about some of the positive success stories we've seen over the last couple of years here in the city of Kenora. So first and foremost, I'd like to talk about the financial impact of community safety and how the city is financially mandated to contribute to many of the services that are a part of addressing the issue here. So you see here about almost 30% of our operating expenditures, this is from 2018, are dedicated towards the Northwestern Health Unit, the KDSB, as well as the OPP. Focusing in on policing, 2019 was especially a challenging year where we saw a rise of about 7% in our policing costs. On a per capita type of basis, that works out to be about $789 per household, whereas the provincial average is about $359. So needless to say, Kenora actually has one of the highest policing costs within Ontario. So when Jeff and Jeff and Henry were both referring to upstream solutions, the city has certainly bought into that because we recognize that to these policing costs and as well as say EMS costs, they aren't sustainable. What's going to really make an impact on these costs is having housing in place, looking at proactive solutions, and I'll definitely go into a little bit more detail about those solutions later on in the presentation. So just talking about community safety in relation to development. So this is kind of my world and what I'm involved in. So we certainly have it as a principle. Whenever we look at a change of land use or a change of zoning or designation, there's certain principles that we have to follow that's under the official plan as well as the provincial policy statement. So a number of them are just identified here above. So staff, when we're working on making a recommendation to council, we have to consider these different principles in doing the work. We also, even after the fact that, or after a change of use, we do have a tool called site plan control. Through that, we're able to mandate certain external features to development to be required. So this could be landscaping, lighting, parking, and some other different things which have been proven to be effective mechanisms for crime prevention. I also like to share this little part of the infographic we shared, I think, it was a number of months ago, but and just re-emphasizing that a principle of our work, and this relates to the Human Rights Code, is that we don't zone for people, we zone for land use. We know that the best economic and social outcomes occur when we have mixed neighborhoods, when we have neighborhoods that don't discriminate based on income or don't discriminate based on race. So this is certainly a principle of our work, and I think it's something really important to emphasize. So looking at some of the recent initiatives, so back in 2018, the municipality joined the Canadian Municipal Network on Crime Prevention. So this is basically a cohort of municipalities across the country dedicated to mobilizing knowledge around crime prevention and looking at striving to foster community safety, well-being. So since joining that in 2018, the city, and actually just, it was almost shortly after, we worked on actually a proposal under the National Crime Prevention Strategy, and this was in conjunction with the Kenora Substance Abuse Mental Health Task Force, and I worked especially close with Bob Burney from the OPP on doing a proposal around missing youth, or missing Indigenous youth, and looking at what the root causes, looking at how we could actually mobilize the knowledge from the study to not only just create local solutions, but also apply it from a regional, perhaps on a national scale. Unfortunately, we were unsuccessful in receiving that funding. However, I think it's very important to emphasize just because of the fact that it was a mobilization of different groups and agencies which I think is what this town really strives to do, which what we're very effective at is rallying agencies around an issue. But also we've engaged a consultant through this network. He's actually Felix Munger, as Jeff indicated earlier. He's going to be helping us facilitate the redevelopment of the community safety wellbeing plan. And here's just a map of the, and I know it's kind of difficult to see, but of the different communities across coast to coast that are part of this network. And I'd like to emphasize that, while Kenora certainly has distinct challenges, every town and city is struggling with the issue of crime, of substance abuse, and mental health. This is the communities represented under the network are about 40% of the Canadian population. So certainly, once again, Bob Bernie and I, we try our best to attend these national teleconferences on a monthly basis, where it's a great opportunity to come share lessons and hear what other municipalities have to say about their efforts. We also worked on, in 2019, various amendments to our zoning bylaw and official plan. So starting with working with the KDSB on their application to rezone a piece of property off of 9th Street for the supportive housing facility they just, or Henry was referring to. So we're very excited about this project. We've completely bought in, and I think it's going to make a significant difference, and I'm hoping for the same outcomes that you saw from the Sioux Lookout example. In May of 2019, we also initiated our own changes to the zoning bylaw and official plan through the allowance of public agencies to develop affordable housing in most zones and designations. So this is a reflection of the fact that we exist, or the city of Kenora exists in a very challenging development environment, one in which appeals are a reality that can delay development up to a year. Looking at outright shortened construction seasons, so we're trying to mitigate that and try to address it. And I think this is a great tool that we now have. We also have the municipal capital facilities bylaw. So in June, council approved this bylaw, which will I think is going to be I'm hoping is going to be effective in incentivizing affordable housing developments in the community. It's basically intended to achieve 3 objectives. The first being a new definition of affordable housing. So one that is more tied to the provincial policy statement, what they consider for the Kenora area low to moderate income earners. So, and I think it's a definition that is much more realistic in the context of affordable housing. I think many of them in the past have been a little bit not very feasible for many developments to move forward. It also provides a framework for the provision of municipal support housing projects. So before, council didn't really have a criteria to go by when assessing a request by somebody to do development. But now we have very much that criteria in place. We look at development support, so that being the extension of municipal servicing. We know that that is very much a huge cost for a developer to do, and that's just simply even on our city lands and extending it up to the property line is a major barrier. And also looking at perhaps tax incentives, so in helping with the operating costs to make sure those rents can be at a attainable rate. And then finally, both incentivize both public and private proponents. Public bodies or governments are really not investing into social housing the way they did in the past. So really what we're looking at is bridging in the private market to the affordable housing type of spectrum. And we do make private proponents eligible under a facilities bylaw, so for which they can enter into agreements with the municipality. And next, I'd like to talk about what many people have said in their comments and questions that were submitted, and that relates to national plan. People want to see what's coming down the line, and I think what I'm most excited about in the municipality is about leading the redevelopment of the community safety wellbeing plan. So I can't say enough about the framework that we already have, or the plan we already have in place that the Substance Abuse and Mental Health Task Force has led. And that has been in place since 2015. But I think as a group, we recognized it needed a bit of a refresh, and definitely with the change of legislation, there was an opportunity for the municipality to take a leading role. And really, this illustration that I have here today kind of indicates that community safety wellbeing model, where the red dot here, the incident response, that's kind of your traditional policing model, where you're talking about the reactionary approach, and that's where you're seeing those huge calls for service or those huge expenditures from a municipality perspective, where it's not sustainable to keep on reacting this way. What you need is a more multi-layered approach. So looking at risk intervention, so identifying vulnerable persons and working with them before they're in a state of crisis. Looking at social development, so that goes to providing housing, providing food security, providing educational payment. We know that having these foundations in place is what's going to be really make sure that vulnerable persons still become vulnerable in the first place. So in terms of community safety well-being planning, while there has been a great plan in place, we recognize that the risks embedded in that plan have shifted. So we look at methamphetamine use, you look at some of the calls for service and how that's changed. We need to update the plan accordingly. We need to do a new risk assessment, and that's based on data and evidence. However, that's not enough. I think we also need to have public buy-in. We need to have public input into it. I think that's very much perception of risk is just as important as what the data and evidence is saying about the risk. So these are the community safety forum as well as the downtown business information session we had earlier. These are fundamental to those to building that risk assessment. So in October, we will be having a facilitated session in which we will be having a consultant come in to help lead that development of an action plan. And it's going to be a broad spectrum of different agencies involved, and this is not intended to be exhaustive. It's going to be, I'm hoping to really create a very, something new and exciting for the community. And then just on this slide here, and that's some of the other comments and concerns expressed were, what are the models to follow? There has to be other communities that have had success, and I think, Glasgow is very much different from Kenora. This has been kind of a leading example of a city that really rallied behind a new model, one that replicates our community safety well-being model to reduce crime in 3 years by 50%. So their issue was knife crime. And by reducing it to that degree, they followed 7 different internationally accredited standards. And when I look at these standards, I don't see many that we don't already have. I think perhaps the 2 that are missing or that we need to work on is adequate funding and resources, as well as public support and engagement. And this new model didn't just simply talk about violence as a public health issue. It also endorsed to put more resources into traditional policing. So I think it's important to remark that we need a complementary type of approach when we're addressing these issues. So when we talk about adequate resources and support for the municipality, this is done through advocacy. So when we work with our federal and provincial partners, as well as different local partners and regional bodies to reinforce a message in which we need more resources and we need more support, especially in smaller communities, and especially in Kenora's case, where it certainly is a hub for the district, and that creates unique systemic issues that not only just require resources, but systemic changes to policy, to criminal justice, to healthcare. So I know these are things that Henry is certainly going to be working on with the All Nations Health Partners, and for which the city is also part of. And when we go to these different conferences to advocate and meet with provincial ministers, we reinforce that messaging, or we work together with KDSB, with other service agencies to create a joint message to drive out change. So we'll be doing that actually in the next couple of weeks. The City of Kenora will be part of a delegation, or have a delegation in Ottawa meeting with provincial ministers on a variety of different issues. So finally, and I think I'm really actually pushing my time here, but I wanted to end on kind of a positive note. So talking about some of the successes we've had as a community. So talking about looking at our downtown, and I strongly believe that we it is something to be proud of despite the issues that we're seeing. If you look at downtown revitalization, from phase 1 to phase 4, there's been a total investment of $30 million into our downtown. And this is a contribution from the city, from the provincial government, as well as the federal government. And it's been proven to create jobs and proven to create positive economic outcomes. You look at wayfinding, so over $500,000 dedicated to ensure that our visitors to Kenora, but also locals, are able to go to the attractions that make Kenora what it is in the destination. Then also the Muse, I think pointing out the $4.5 million art center, which is going to be certainly unique in the region, and it's certainly a great case study in which you have public and private partners coming together to make truly a unique cultural institution. Also, we build on our community. So I'm talking outside of our downtown. If you look at our community improvement planning, the city has dedicated since 2007 over $800,000 towards the CIP program, which has further leveraged $2.1 million from the private sector. So businesses throughout in the Harbortown Center, in Keewatin, and on the Millville, not so much the Mill property, but definitely in those two areas, there's been quite a bit of activity and looking at business investment. And then enhancing public spaces. So in Norman, in Narrow Park, you're looking at almost $2 million that have been dedicated over the last 3 years, both publicly and privately, to improve those assets, to make them age-friendly, to make them really reflective of the next generation, the youth, and embracing that. So I think these are really important things to remark upon. And also just, once again, here's just some pictures of different projects, but I think it's, we should be proud of the things that we've accomplished over the next few years, and we should refrain from, looking at perpetuating fear and being so bound in it. I think we should be hopeful and rally around the assets we do have in this community. So I think that with that, I'd like to perhaps go into the Q&A period if we do have a bit of time left. So.
Queue behind the microphones, which are located at both ends of the room. We'll go back and forth, and when you come up, we would like you to please state your name, who you're directing your question to on the panel, and what your question is. Again, the way we worked it earlier today, we know what the issues are, so we don't need to, go back over that as much as we want to hear your questions so you can gather additional information from the panelists. So, saying that, we'll start from this end, please.
Good evening. My name is Shelley Chapa. I've only lived in Kenora for a couple of years, but I go back to like the 50s with my parents who originally settled here. And my question is, I don't understand why they are closing down the shelter, which has been such a valuable resource to Kenora and the homeless people, why they would close it for 6 weeks, and what are these people supposed to do?
Thank you.
Good question. So part of that time is looking at making some changes inside the shelters and service up structurally to make sure that programs can come in that have been identified by service providers in terms of what they would need. But also I can tell you that we're working really hard right now to make sure that there are safety plans in place in between that we're working with community partners to see if they're not places that we can even open up temporarily to provide support overnight as well. And so that's what we're going to be doing over the next 2 weeks, to really make sure that we have that in place. And then when that service hub reopens, that we're supporting people, and that the staff and the service providers there have the resources that they need to address the challenges and the changing challenges that our community is facing.
Richard Green, because you're going to go down my push not my whip. Ma Chinela and the Ma in the Kimina. The people that were here first, and the indigenous people, and I just want to make a statement that we're still regarded as being in the way of our people are not regarded as equals. There used to be still an attitude of white privilege, and but I want to say some encouraging stuff. I'm glad Mr. Wall was there's some opportunities there, some hopefulness that he cited, that we needed to respond quickly and with purpose. I've been coming to Mike's, I've been coming to meetings for many years. I've been living tomorrow all my life. But I see the marginalization of our people. And we think we can start here, it started in the Confederation times. When McDonald suggested that we have an Indian problem, and the attitude is still ingrained in Kenora. and elsewhere in the world, in Oka. You know, they're being surrounded by Mohawks. Stuff like that is not helpful. We need to have a different attitude. I'm pleading that we have a different attitude of what we're trying to do. We had Harvard, we had all the universities, education institutions, they haven't solved anything. We have amounts of the problem still lingers. We have the overrepresentation at the jail of our people. 95%, maybe 98%. And we're nowhere close to what we need to see. We have to say it bluntly, we have an Indian problem, say so, because we need to know so we can start, working our attitudes to make it work. What's going to work for you? What's going to work for Kenora? We need to say it straight out. Call it spade a spade, you know. It's problematic that way. We need to work on that. We see our young girls. I just about tried stats that Mr. Wall presented for girls. How they're greatly affected. 18-year-olds. I don't know. These are major issues. These are big issues. They're huge. And I needed, and I could say different things about the presenters also. You know, we still feel unsafe with the police. We still feel unsafe even our own services. We can't go in there. And Patty, I'm sorry that, even our people are good with your place. Because they don't feel welcome there. The language is not fostered. And so that's how it is. We got to say, we can't paint a picture of it seems like it's all good and well with the Friendship Center. It's not. There's a bunch of programs, but they're not working for the urban Aboriginals. I've tried to be a member of the board. I was told I can't. I lived here all my life. I got to wait 1 year so they can accept me on the board. Stuff like that is too much. And the punitive measures that are given to the people at the center, it's not working. So, yes, go ahead. I'm sorry I apologize for taking so long, but I just want to, I like this form, but there's still barriers in the form also that, how to get in. We're unable to access even this form. I had to get a ticket from, I had to get Rory McMillan's ticket to come in. But I got connections, right?
My name is Shelley Moncrief. Richard, I know through Jubilee Church, and I honor you and your First Peoples as well in this area. I'm here to represent my community and the residents. I am the person who owns the home right beside the shelter. I'm ground zero. What I have witnessed in the months that has been happening since February, I would challenge anybody in this community to come and live there. The violence that takes place, the screaming, the yelling amongst themselves as they're coming off their highs, the feces and the urine in your yards, the vomit in your yard, the needles. I have 3 young granddaughters that I will not allow to come and play in my yard anymore because of the needles I found in my yard. That also needs to be addressed. Very seriously. I would like to know for the safety and the well-being of the residents. First I want to say thank you sincerely to each of you as the agencies and everybody in leadership in our community, because I know you're trying to do your best. But when it does hit to the core, what do we as the residents do when we are confronted with this? When you're woken up night after night because of the violence next door? Honestly. And it breaks my heart, yes, for these people. But we all have somebody that we know that has addictions, and unless that individual wants to get well, they themselves, we are enabling them. I thank you, Jeff, sincerely, because your men have been amazing. I do not call, I have actually chosen to leave my home since April. I'm no longer there. I come there only to sleep and to cut my grass. And even in that, I am still being waken up with the violence even in my front yard. I did not want to leave my home. So what do you say to somebody like the residents in that, and the business people in that immediate area who live in it 24/7? And would any of you come and move to my home and trade homes with me, sincerely? That's my question.
And a quick answer to your question, I mean, what can we do to make that area safe? I think we are trying. It's a struggle, you know that. Yeah. We're increasing our foot patrols. We're doing all we can, but all the things that we've talked about today have to fall in line. Right? We can't help anybody unless we have the resources to do that. Are we enabling people? I mean, how so are we enabling them? As the police, we're trying to enforce the laws. We're asking people to call us if there's issues. Clearly, we're in that neighborhood a lot, but we can't be everywhere, so we're asking people to call us when there's issues. Would I trade with you? No.
It's a four-bedroom home. You got 3 children. I have 3 children.
Yeah. But we also can't, you know, when we talk about building sustainable housing, supported housing, it can't be a model like we have now. It can't be the Minto area. It can't be all together. It has to be spread out. Is it the perfect location? I think we can all say it's not the perfect location. Exactly. But it is the location that we have, and how do we make it work? So what are we doing about that? I mean, we're bringing in the Main Street project in Winnipeg to talk to us about how they operate their shelter, what clients they have with their shelter. We're making those connections. We're doing the best we can, and I think this 45 days is going to show us that we do need a shelter. And you know, in those 45 days, we're going to do what we can to make it work.
And at the expense and the well-being of the residents and the businesses there.
Yeah, and the people that use the shelter are residents of Kenora too. You have to say, like I said in my presentation, we can't choose who makes Kenora home. We can't choose to have people that move into our community that can afford houses and jobs and everything else. We have to provide them an opportunity with supportive housing to break that cycle. And we can't do that overnight.
Are they willing to break that cycle?
We have to give them a chance to. That's
and you don't feel that we have in Kenora over these years?
Okay, Shelley, because we have a lot of people, I kind of like to let other people.
We got a lot of people.
Please.
First of all, thank you very much for all of the information and for having the forum tonight. My name is Ruth Hillman, and I'm here just representing a very small group of volunteers. And the group that I volunteer with is called Helping Hands. I volunteered with them for 5 years. They've been worked out of Jubilee Church every Monday and Tuesday, and right now, currently, we are volunteering at the shelter every Monday and Tuesday from 4 to 6. I guess I would just ask those of you who are involved in the review of the shelter, please, please, please communicate with your volunteers. Please consult us. Please involve us. I'm not here year-round, but the other volunteers are here year-round, and they have done this for a long time, and they would love to be consulted and to be involved. Please also communicate with those volunteers that we've lost since the shelter opened. There are a number of them. There are a number of volunteer groups who provided the food supports throughout the last few years, the other evenings and the other days other than Mondays and Tuesdays. Those groups are also volunteers. We're partners, just the same as organizations and agencies. We're partners and we're here to help. I'd even challenge you a little bit there, Patty. You say maybe just 2 people involved with some of the meals, but when you're slugging the dishes and the dishwashers and all of the other stuff that goes on, just to help the cooks out and to help the staff, volunteers will be there for you and will be a support for you, but please consult, please involve us, and I can give you names, and we'd be glad to provide support and assistance. I do want to say one thing. I do want to commend the young staff and the cooks. I know that there were difficulties at the beginning. I know that there have been supports recently, and I can tell you that in the past 3 months, I feel safe there. It's a positive environment inside. Inside is good, and the staff is working hard, and I commend them for that.
Hi, Jen Lasso. So I wanted to ask Jill a question. It was brought up to me at the morning meeting. Somebody emailed me to tell me that at today's meeting you said that needles have been returned. Their question was from people using the needles, clients, or from the general public. So I don't know.
So you're probably talking about the return rate that I talked about?
Yeah.
So we had, whatever I said we had. So
Like 238,000.
Yeah, I think 79% return rate in Kenora last year. So that's the total number of needles we get back. So that includes from clients, needles that we might pick up in the community, or needles that are returned to us from other people in the community. From our drop boxes.
Good. Yeah. Perfect. The other question I wanted to ask Henry was, you're looking at building more supportive housing units on 9th Street North. That's what you just said at this meeting. But now I'm going to say it as well as Jeff said it. You told me in 3 meetings that the hub in Minto and Cambrian are not successful. Everyone in that area, it needs to spread out in the community. So why are you going to build it there?
It is a good location. In terms of what we've heard back from the community through our consultation and so forth, is that there's a recognition that 20 isn't enough, and we're asked if we can do more. And so that's why I mentioned is that we're looking at everything. We know we need more in this community, so we're looking at all options.
So on that site or on a different location?
It was asked on that site because I'm just saying we're looking at it. That's all I'm saying.
But speaking like Jeff said, Minto and Cambrian doesn't work, so we have to figure that out.
When I refer to that, and we know what's up in Minto and Cambrian, they're row housing, they're not supported. This is completely different. This housing unit works in Sulico, it's proven. it supports people, and it's a supportive housing unit. It's not go live on your own. There's rules, there's locked doors. Some people are not allowed in. If there's issues, the police are called, because there's staff there 24/7. So when I say that the projects in Minto and Rilo, they don't work, this is different than those projects. And I will say that, we're building 1 30-unit apartment, we need 10 of them. We need them to be supported, because we need people to be there to look after these people. Because we're going to put people in there that maybe haven't lived on their own, that need those supports. They need that community feeling, and that's what will make it successful.
Good evening, everybody. My name is Charles Rossru, but everybody calls me Chucky. So, before I moved to Kenora, I was living in Calgary. I worked as a mechanic at the go-kart track place, but I like to consider myself the jack of all trades. I worked at the Calgary Drop-In Center, where I helped out 600 people for food and all that. I always love helping people, dispute my thoughts, upbringing. I was into almost all the drugs until 3 months ago, but at this shelter I found purpose because of the staff and patrons who felt like family. I started cooking. I started volunteering as a cook every day, and have started a new positive chapter in my life at age 41. Now I have a few questions for Dan Mayor. Do you think it's right, or do you think it's wrong or right to close the doors at this shelter? I think it's wrong, and it's not right. What are you going to do about it?
Okay, the shelter operation does not fall under the city of Kenora. We don't operate it, we don't have people on the board that make those decisions. The city of Kenora has supported, we believe that the shelter is important. That's why we supported it when the planning issue came forward. So, not being part of the decision, I'm not going to comment on that. What I'm hopeful about is that based on the direction they're going, they want to come back and make it so it works for the people that need it. And from the sounds of it, you sound like a classic example of somebody that benefited from the program. So again, the city will continue to support what we can, but we're not directly involved in the decisions or the funding of either program.
I got one more question for Jeff Duggan. If a homeowner finds a patron or a homeless person in their yard and they need help and they refuse, what do you do?
So your question is if a homeowner finds somebody in their yard
Laying down in the grass,
Yep.
and asking for help, and the homeowner refuses not to help them.
the homeowner, well, we would hope that the homeowner would call either an ambulance or the police. That would be our first hope. If they do call the police, we will go and assess what that person needs. If they need an ambulance, we will call one. We have many services and supports available to us. If that person is at acutely elevated risk, they'll be brought to the risk table, or there'll be a plan put in place for that person. The more people we can keep out of the criminal justice system, the better, so we will hook them up with the services that we have in this community.
Sucks being tall. For those of you here who don't know me, I'm Chad. I'm married, got a wife and 3 kids, born and raised in town. It's an awesome town. But I'm not against the homeless shelter. I'm against the drug problem. And none of you here have addressed that. My business, I have 5, okay? 5 of them. And one of them is on Ottawa Street, the main content core of it. There's a drug house 2 doors up from my storefront. People are afraid to come into my store and buy food. The elderly are afraid to buy food. They can't walk down and buy food. They don't want to. They feel unsafe. I've taken steps to walk out my front door and see cars parked in my lot. I walk up to them, I wave to them, I picture text them, and they take off. They're parking it in my lot to go buy drugs 2 doors down. I've asked many cop friends of mine, please come stand in my store all day and night. I'll give you the keys. I'll feed you guys. I don't care. Look at the nonsense. I'm keeping it tame here of what's going on. There's one more place next door to me. Same problem. Drug addicts walking through the yards, buying drugs, walking back again. This goes on 24/7. I work virtually all day and night. I'm there 5 a.m., 2 a.m., 3 a.m. in the morning because people gotta eat. This goes on constantly. So my question to you guys, mainly Mayor Dan and Jeff, what are you guys gonna do to shut these drug houses down? That is the problem first of all. Let's address the problem. Please, come to my store. Stand in the window, watch all the bullshit going on. I'm sick of it. Everybody else is. I've seen maybe 2, 3 cars drive past the road. They don't get out and walk and maybe check out what's going on. Park in front of the drug house. Stop it. Shut it down. I am losing money. My business is losing money. This morning I met my banker. I told her, in 2 months' time, I don't know how I'm going to pay your mortgage because I'm losing money every day. The business incubating my food trucks because people don't want to buy food, walk downtown and see drug deals. Buy a hot dog, do a drug deal. I cater all over. And all I hear from the guests I have is, we don't want to go downtown. We don't feel safe. Shut the druggies down. I'm trying to be as politically correct as I can. Shut them down. What are you guys going to do to shut them down?
I can answer that. I mean, so can Mayor Dan, I'm sure. But so we do have the Organized Crime Enforcement Bureau and the Community Street Crime Unit that do drug enforcement. Unfortunately, you won't see them because that's what they're designed to do, is blend in and collect surveillance and do intelligence.
I text them. I have picture phone on my desk of the narc guys I know, and I text them. And I have no comment back.
So that's something that needs to be brought to my attention. If you're calling the police and you're not getting a response to that, we can certainly address that. We have several areas in town that we're looking at. Of course, we're not going to go into that. Last night we executed 2 search warrants on drug houses. So we are doing that. And we do not hear about it, but we are doing it. It is extremely difficult to do with our judicial system and the way that the system is set up. The intelligence that has to be gathered, the evidence that has to be gathered to apply for search warrants. It's a difficult process, but it's a process we're used to and we are doing it. I wish we could do more of it, and that's something we're looking at, putting more resources into that. It's, yeah, we have a strategy. We're doing things. We're doing things you don't know about. But if we're not at the point where we know we can get a search warrant for a house, then it takes time to collect that intelligence. And there are several locations in town that we're looking at.
805 Otter Street.
Now everybody in the room knows where it is, so everybody.
Okay, we gotta move. It's gonna move along. Mayor Dan, what are you gonna do?
Okay, let's be, what I always tell people is the city is not, we can't do everything for everyone. We don't build houses. We don't run healthcare. We don't provide police services. Jeff Duggan and his team are the people that enforce the law. So I'm not sure what you expect the city to do, because do you have a suggestion of what you want me as
I
mayor
can't
to do?
leave my vehicle parked on the street for more than 24 hours without getting a note. No, but hang on, without getting a note saying, please move your vehicle. But the city allows drug houses to operate. How is that fair?
I'm pretty sure we don't issue business licenses for people who run drug houses.
No, but you guys, everybody here knows where the drug homes are, right? So,
I couldn't tell you
evict
where
them,
one
get them out. But you guys don't care about that. All you guys want to do is solve the problem after the fact. Well, let's get them high first. That makes no sense. And businesses like me and Pam and a lot more who I talk to who don't want to come here and say this stuff, they're losing business. This is the first time in 18 years I'm having to potentially lay off staff. I've never done that this time of the year because the income is not there, because people aren't coming to buy the product. So something's got to be fixed about this. This is ridiculous.
Hi, my name is Laura Slate, and I'm born and raised in Kenora. My first question is for Jillian. You quoted statistics from Saskatchewan and Indiana or wherever. I'm wondering what statistics are for Kenora with HIV, and has there been any change since the implementation of the needle program?
Thank you, Laura. Yeah, so one of the jobs we do in public health is any reportable infectious disease. Anyone in our catchment area, so bigger than Kenora, test positive for lots of infections from HIV, hepatitis B, hepatitis C, syphilis, chlamydia, gonorrhea. We receive those reports and we do surveillance. So far, our rates of HIV have remained lower than the province. And that has been across the board. We implemented this program really early on, very early on in the 90s, where places like Ottawa were experiencing high amounts of HIV. We didn't quite see it here the same. So we have maintained a very lower than average rate in Ontario, compared to Ontario.
Okay, and another question for Patty. When the patrons come to the homeless shelter and look for somewhere to stay, while they are there, are they encouraged to pitch in, do the laundry, help with the cooking, clean up around the homeless shelter, things like that?
Yes, they are. And they do their own laundries.
Another thing, just one more, sorry. I drive by the Knox every day, going to and from work. I live in the neighborhood. What I see going on out there is very sad, on the outside, not the inside. And there has been many incidences of them shooting up in public, right there, starting a fire, cooking their stuff, and injecting it. As a resident, it is broad daylight. I would love to go in there and say, stop, please, get some help, but stop doing this in public where everyone can see it. And we all have family members with addictions, Lord knows, we all do. But how do we stop this public display every day that goes on outside the Knox United Church, and it carries on down the street and across? I saw a family going into Brown's funeral home, and they had to request that the street people move so they could go in to make their arrangements. I find that very, very sad.
Before I get to my question, the lady sitting next to me was a little bit shy. She brought up a good point. We've listened to how well you're all working together tonight. She runs the Knox, she runs the thing. She didn't know what's closing. Can't be working together too well. Before I get to my question to the mayor, okay, I'm a cab driver in Kenora for 4 years. I didn't know Kenora sucked until I started driving a cab. I offered the mayor in City Hall, they don't know what's going on, get in my cab, I'll show you for free. Right in City Hall, I'll offer everybody, let's go for a ride. They're right. You want to buy meth? Ask a cabbie. You want to buy a bootlegger? Ask a cabbie. Where do they all live? Kenora District Service Board Housing. And in Minto. That's where most of them come from. Your houses on Pine Portage are disgusting. Don't you guys go in and check? I drop people off, they stagger in, they're coming out with needles. Most of these people are in your housing. As for the needle exchange, we're not here for the needle exchange. We're here for our safety. The needle exchange does nothing to curb violence or theft. It only curbs drug or diseases going around. It does nothing for violence. Not a single bit. He brought up the 911 call for the police scanner. What an interesting thing to listen to on a Friday night. 911, Whitefish Bay. My boyfriend sold my telephone. 911. No, I'm just bringing up your. We got lots of time. I'm bringing up the point. We do. Are you in a hurry? I'm bringing up points. What's wrong with what you said? This here. I will get to a question, but questions. If you're in a hurry, Mr. Mayor, you can leave. See the picture of the splash park. What does that do to curb violence? Nothing. Absolutely nothing. Meth is not new. Meth has been here since World War II. The Germans invented meth, and then the Americans and Canadians started feeding it to their pilots to keep them awake. So you want to blame meth? Blame the government. That's where it came from. Same as the Vikings did with magic mushrooms. Let's keep them and go to war. Okay, Mr. Mayor, you say this has nothing to do with you. Mr. Crop is losing business. I've been studying this crap since I started driving cab. You guys in City Hall do not get out. Actually, you have no clue what's going on. Blue lighting was started in Europe 2 years ago. It has now moved into the stores of Toronto. This is about our safety. If you can put blue lighting in the bathrooms, it curbs drug use. My answer from an email from Mrs. Brown was, I have to ask the health unit. The health unit doesn't want it because a druggie can't see their blue vein and they might hurt themselves sticking the needle in. So, there's no more blue lighting. Why would you not take our side, save crop, and get the junkies out of our public bathrooms? It won't stop them from shooting out, but it makes the downtown core safer, and that's why we're here.
I remember you being a cab driver, and you were saying all kinds of nasty comments about Native people. I remember that. Yes, I had to sit him down too because I've been in his cab. And he says some pretty nasty stuff about Minto and my people. I challenge you right now. Admit what you did.
Okay. I just want to go out and make clear, you do not own this, you don't have housing on Pine Portage. So I think this is a common misconception.
It says Kenora District Service Border 1400 there, right on the sign.
Oh, I don't have housing units on Pine Portage.
It's the winter sign.
I did have a couple of questions, but I'm already with my client said, Dan said earlier, after the announcement on Monday, I was really kind of vacant. We need this service in our community. Does it need work? Absolutely. But we need it. Our people need it. Being keyboard warriors on Facebook doesn't solve anything. Pointing fingers doesn't solve anything. So I was thinking, what could I possibly do? Not on a planning committee, but I was thinking about my time when I was in school. I did placement at Main Street protest. Jeff talked about it. And I've always thought about this place. It stuck with me. The work that they do is amazing. The services that they provide are evidence-based, housing first, services available in one spot. They have access to healthcare. They have access to treatment. They partner with their Winnipeg paramedics to provide healthcare on the spot should they need it, or require it, or ask for it. So what I did was I sent an email to the Main Street Project on Monday, and I heard back from them within 24 hours.
So yesterday, I had a really great conversation with Adrienne Dudek, who is the Director of Supportive and Transitional Housing for the Main Street Project. And when I told her what's happening to our shelter, she was shocked. And she is completely on board to partner with Kenora to make our shelter a success. She will share their policies, their security measures. She will share anything she can with any partner at the table or at the planning table. Anything she can offer, she will provide. She mentioned that Bob Burney actually had a tour of the facility in June, and he actually arranged for a presentation to the Kenora Biz, because the Main Street Project partners with the Winnipeg Biz downtown. So they want to see how that worked. So she said, you know what, Andrew, I'm coming to Kenora on August 19th. Why don't I come a day early or on a day that works, that I can meet with people, I can do a tour of the facility, I'll offer anything I can. She said, Kenora has a partner with the Main Street Project. So I just really, she encouraged me to bring this, our conversation tonight, because I told her what was going on. And I sent her information to my colleagues at the health unit, in the outreach team, so they'll be talking. So there's another avenue that you can tap into for resources to make this a success that we need.
Just to address that point, you are correct. Our officers did. We had 3 officers go to Winnipeg and tour the Main Street Project. There is a great connection there with the Main Street Project. They've been very helpful. They are coming on the 19th to speak to us, to tell us and tour our facilities. They're also interested in things that we're doing here that they're not doing, so it is a mutual benefit. They're going to be touring our detox center, looking at our MAP program, so we're going to be exchanging a lot of information, and it's going to go both ways. We're going to learn from them, they're going to learn from us, and I'm sure it'll be very fruitful.
So the shelter will be closed at that time?
It'll be closed on the 19th, but I mean, we'll have access, I'm sure, and we'll have tours, and we'll talk about security, and we'll talk about what they do and what we do. They do run a paramedic program out of the shelter, which is fantastic. You know, that's definitely something that costs money, but it's something to be looked at. They run a whole host of things out of that project. One of the main, and I didn't go, but we had officers go, I was briefed after. They have the full support of the business community around there because they need to have that. They do also have the housing supports around there that they've attained over the years, because the Main Street Project isn't brand new. It's been around for a while. They went through learning lessons like we're doing, and they're succeeding. So we hope to be there at some point.
Hi, I'm Larissa Meisner. I own the building next to the shelter. So very similar to Shelley, we have the same issues every day. Jeff, you know your officers are in my office daily, 3-4 times often. I think the big thing is that I'm hearing tonight, Henry, you promised the last time when you did the first presentation with Knox that you were going to do the life skills and you were doing the addictions and all those things would be in place before you opened. Still not in place 6 months later, and now you're promising again. I think that was why the call to action to shut down the shelter was, so everyone understands that. Those things are not in place. It is not safe for the people around there. It is not safe for my staff to be in their building by themselves. We have to lock ourselves in. The downtown businesses are locking their doors because they're not feeling safe. You heard from Pam from Cornerstone the other day. People are losing business. Kenora businesses, Dan, are hurting badly. Tourists are not coming downtown. But what I'm hearing today from Henry and Patty, both of you, you both said this is not the ideal location. It's not the size that you needed. You're short on space. Why is it there? Why isn't it at Knox Church? I know they needed the money, and it was a bit of a sellout. But why is that where the shelter is if you're feeling you don't have the space and it's in an area that is really, really compounding issues in downtown Kenora?
we didn't say that it was location. It's certainly in terms of resources and everything that's happened in the last couple of months in regards to buildings that were destroyed by fire, the construction that's happening in our downtown. What it's done is squeeze a lot of items and issues right over to where the service hub is. And so this is where we do need to regroup, and I can assure you and the community that we're doing everything that we need to do to ensure that when it does open, that we have the resources, we have the assurance from the province that they're going to support this, to make sure that when we're back at this, that the resources are there to make this happen, make it a success. So, and we just need this time to regroup, and we can't just keep us tight on to just keep going on in a crisis situation.
That's the same story that you said 6 months ago.
Hi, I actually am from Kenora. I live in town because I don't like bringing in my lifestyle choices and things like that out to my reserve. Also, I've been an addict for probably 7 years. This is struggle trying to stay sober. One of the things that's hard is the impact that public has on addicts. Sorry. The using on the streets and out in the open is very bad. I can admit that. I see that, and it's horrible. I also read that Justin Trudeau had offered us safe injections, and it was vetoed by the city of Kenora, saying that the opioid crisis was over. But clearly it's not. So that would be one of my questions as to why that was vetoed. I think that if there was a safe injection site, a lot of the drug use would stop. There would be somewhere for people to go and not be seen on the street using. There would most likely be people there to reach out to if you needed help getting sober and getting help. Yeah, that's true.
Thank you.
George Smith.
In my time on council, that has never, the city of Kenora has never been opposed having a safe injection site. CEO, your time.
I've been with the town of Kenora since 1992, and we've given the opportunity to talk to the often talk about what the instructions are.
I've read it in the news.
I read in the news that we had $132 million surplus too.
Fair enough.
Jillian can address the safety connection site question came up earlier today.
Hi.
He's also a you're quite a guitar player.
Thank you.
It's something that we've been looking at for a while, Jerry, and it wouldn't just be the Northwestern Council. It would start when we get the partners for that, and we're open to it. And I think you're right. I think that things have to change in order to turn us to look at that. It's we need that. So one of the things we talked about earlier, which is which is what has to happen before you have one. And the center is doing one right now, where you have to look at, okay, what is the evidence that we might do this? Talking to the people who use this, where is it? And looking at all the things we have to before we decide to use resources to do it. So we've applied for funding to. Oh, sorry. All of it? Yeah. Start again.
Thank you, Dory. So Dory's right. So supervised consumption sites is something that can help communities. It can help decrease needles on the ground. It can help decrease overdose deaths. It can get people connected into services sooner, like you said. And it can overall help people, and they do really good things. They're evidence-based, and they've worked in a lot of areas in Canada. Most of the places where they've been implemented are larger urban centers. Thunder Bay has a provincial version of it, and Sudbury's just looking at getting one as well. So it's starting to happen a little more in our area as well. And something else like Jory said, we're hearing a little more about that public injecting, so that's definitely something that these sites can help with. So we were thinking that we might want to move forward with a feasibility study where you look at, is this something that we would need in our community? Looking at the evidence has to guide you in this kind of thing. You can't just think it's something that you need. Because it might not be that this is what we need, it might be something totally different. So you can do a feasibility study where you look at what is the evidence that we might need one, where would it need to be in order for it to work, and what would be the impact if we had one. So we're looking at doing that. If we get the funding, we'll be doing a feasibility study, and the evidence will guide us on that. But yeah, you're right, it's a really good idea.
Also, with the hospital, there's a lot of trouble there trying to get health care. I actually had a cyst in my spine. I had an infection in the bone of my spine, and I almost lost my ability to walk because I was told constantly to go home and get physiotherapy or yoga. I had actually went there and said that I don't need pain medication. I have my own pain medication, and still the doctor told me I don't want pain meds. So there's a real problem with judgment and discrimination in homeless people, mental health, people with mental health issues, and addicts. I think there needs to be awareness spread. A lot of people are afraid or hate because they don't know. And basically an addict's living in hell. Like, I would never want to do this or have anyone do this. And it's really hard. And the fact it's not a joke either, but have you guys thought of asking Bill Gates? Away like half of his estate. During his retirement, he's helping people across the world. Like, I don't know if that is actually a joke that Bill Gates thinks, but like, if you guys propose something to him, like I'm sure he'd probably help you. Something like a shelter, but for people actually to have a place to call their own, and build a stable and balanced lifestyle, so that they can start to make the leap to quit. It's really hard trying to quit or getting a job when you have nowhere to live. There's a huge problem, and a lot of it is mental health issues. A lot of it is because people are addicts, and when you're an addict, you don't have any chance to grow because you're constantly looking for that drug to keep fun. And if you can have a stable lifestyle and a place to call your own, then you're much, and the public impact. If people drive by the homeless shelter constantly, some of them drive slow, some of them shout things, some of them, and I have nothing against anybody. I'm legitimate, like, I'm Métis, like, one of my grandparents is white, one's Native, and the other two are half-breed, so I don't have any, like, racial judgment towards anyone. There's just as many racist Native people as there are white people. And it's because of, years ago, and residential schools and stuff like that, but like most of us have gone past that. Like my parents weren't even in residential school, so like
You've raised some very good questions, and I have to say that for you to stand up in front of everybody, especially most people you don't know, it takes a lot of courage. I hope it's okay if we move on. Thank you very much.
Thanks, George.
Were you going to ask a question? Oh, I didn't see it.
Hi, I'm Johnny Rainbow, and that's this gets right to the point. He's asked for what my question is. Does Greg or Jeff or Henry read the Free Press today? Has anybody called Marion Willis? He's asking for he's asking for it. The hub failed because it promised too many things. A shelter for those who are chronically homeless is one thing for whatever reason. The right place for individuals habitually using opiates and or meth is quite another thing and needs to be approached quite differently. The Knox location could easily be renovated into a treatment transition residence for 15 or so individuals who seriously want help, like this gentleman we just heard from. Based on the Moorburg House model, it would not disrupt the neighborhood. Marion is willing to come down and talk to you. She is quite familiar with the Main Street project as well. In fact, it considers that as something to be considered and included, but not a standalone solution. There is no one standalone solution. This facility would be run by health professionals and staffed by students doing their practicum. Makes it affordable. Housing is the follow-up piece, which Henry is working on. And then along with supports from our 18 mental health agencies here on the route to recovery. The shelter, it needs to be a different animal altogether. It presents different challenges. Plenty of things can go wrong. Its clients can view it as a viable lifestyle, fostering the never-ending cycle of poverty and a trap for possible addiction. It can become a base for criminal activity. So when the Fellowship Emergency Shelter closed July 1st, 2016, and Mayor Canfield declared a state of emergency to bring provincial and federal money to the table, the outcome has been less than desirable with the one-stop shop hub approach. These things need to be separated. Ending homelessness completely is not realistic, because some people choose it, wittingly or otherwise. Reducing its viability as a lifestyle option just might keep a few more in school education. My question is, has anybody called Marion Willis yet?
And you know as well as I do, I have that information from you. Have I called her yet? No, I have not. But it is somewhere that we can go and do a tour of and see if that's going to be.
She's willing to come here and talk to people.
Well, it's better for us to go there and see what she has, and see how she runs it, and see if we may have a program that runs similar to it or something that we can adapt here for sure. But you have provided that information. It's something we'll follow up on. But have we done it yet? No, we haven't. I haven't.
If you read the paper today, you will see it's a very similar situation. There's a building with a 20-year lease that is it's been out of use for a lot longer than the 45 days that you planned, but it's in a very similar situation, and I think what the last gentleman just mentioned, he wants a place to go that works. It's a house, it's a residence with respect, where they take care of each other. And maybe he'll get straight because he wants to. This is the place we need.
You know something, John? Part of the goal tonight was, not to hear horror stories, but to actually try and find solutions. So thank you for bringing that forward.
Well, my name is Bradley Scott King. I actually took over running the kitchen at the homeless shelter 4 weeks ago. I come from a wealth of experience cooking, and I love working there. When I first started, I literally seen a lot of angry looks on people's faces. Maybe it was because of things they were going through. I've seen a lot of helplessness. I've seen a lot of drunkenness, probably drugged out people there coming in. But I'm not about that. I'm about cooking and food, and my food is medicine. I'm there offering a service to these people, and I can't speak to the drug problem or the alcohol problem. I know that needs work. I've been through my own battles with drugs and alcohol. I'm going on 10 years sober. I've worked in youth addictions. I've worked with children, families, and youth. I've been a cook and chef for over 20 plus years, and I combine those two. I'm a frontline worker, cooking in that kitchen, dealing with people that come in there, and my food is medicine. I thank these volunteers that come in here on a daily basis and help me out. I thank God for those volunteers. I thank God for the food that's donated on a daily basis to us. I don't know where the budget comes from, with Patty, and where does this money come from for the food to serve these people, because I know we need more. We need more money. Badly. I'm there looking and working. And so I can't plan a 3-week menu or a 2-week menu or even a 1-week menu because there's not that product there. So you can't declare a state of emergency from Kenora if you're not willing to put your money where your mouth is. Where does the federal government, where does the provincial government come in? Where does all this money come in? If Thunder Bay can cook for 350 people a day, and Winnipeg can cook for all these people, why can't we? It's just food, right? It's not a bad thing. I'm just asking a question. How does that funding come about? Where does that come in? I'm just there cooking, and I love to cook, and my food is medicine.
All your work. And how in terms of between now and when it reopens, we're doing everything we can to work with the provincial government and all levels of government to get the table at this point. This can't just be done by a couple of agencies, a couple of organizations, or just by this community.
Thank you.
Hi, my name is Liz Visser. I am a 7-year resident of the downtown core without incident. I also have had the honor of working with high-risk and vulnerable youth in our community. One of the things that I'm worried about with the shelter closing is how we're going to protect the young girls. From my vantage point where I live, trafficking happens daily, solicitation happens daily. There's Johns out there, and there's pimps that are monetizing the exploitation of these girls. So is there a plan during these 6 weeks to protect them?
So part of this process too is to make sure that when it reopens through that, ensure the safety as well for people staying there. And I can tell you that staff and other organizations in the community are working to see how do we ensure that people aren't getting hurt through this program.
Okay, and I guess a follow-up for Jeff Juggin. If we...
Can I just touch on that really quick? With regards to female youth trafficking, we do have a youth mobile crisis team that works with those youth. And we're certainly going to be vigilant in the next 6 weeks as to where they are, what they're doing. And certainly if any of them reach out for help, that team will be there. 2 police officers and a social worker, and they've had success with removing females to treatment, to programs, to safety before, so we're definitely going to be vigilant.
Is there a number that, like, say, if I see it happening, that I can call? Because I see it happening regularly.
Yep, we can talk after.
Okay, perfect.
I can give you some.
Thank you. Yeah. Or maybe everybody.
I guess there's more people who would like to.
If you're, I mean, if you're seeing general crimes taking place, the 911, the 188 number, if you have specific information on what's happening and who's doing it, that's a different avenue that we'd like to collect that information.
I do.
So, yeah. I'm not going to give out all the officers' cell phone numbers, so you have mine, so I'm not going to push someone to the bus and give theirs over here.
Please.
Hi, my name is Andrew Page. I just started working for the Northwestern Health Unit in Elevate last Tuesday, and before that I was working for Big Lake Fiberglass, and I'm still doing both jobs actively. I was volunteering my time at the Northwestern Health Unit before I was hired on to Elevate, doing a music program at the Jubilee Church. I'm sure you've heard of it, between 10 and 2, and it went on every Friday. We had band and pizza, substance use delay, arts and crafts, music. Right? It was dubbed my program, and even though it was Calvin Ski that actually put it all together, I was on with the members of the Northwestern Health Unit funding the entire thing. It stopped when I started working at Big Lake Fiberglass full time. I working just over minimum wage at part-time hours, and I'm finding it nearly impossible to try and keep myself fed and my roof over my head right now. What I've been doing in my own time is not doing a music program at the church, but instead I've taken my own initiative and I'm doing it on my own time every single day on the streets, and you may have seen me playing the piano or the guitar or singing or what have you. I've met many musicians in the past couple weeks, and I'm doing this on my own time without any funding at all. And I'm still doing the same thing at the church. When I have a few bucks, I'll take people for something to eat. I'm also dedicating my time fully to help people talk about suicide. I don't know if anybody in this room has ever seriously talked to somebody about taking their own lives, but I've chosen to do this on my own time while I'm at work and while I'm at home while I'm doing my substance use delay. In the past 10 weeks, I've talked 12 people out of suicide, and they are still walking around, talking, laughing, living. Like I said, it's all volunteer work, and before I started working at the Northwestern Health Unit, they were my friends as well. I'm a high-functioning alcoholic, and I have been for 15 years. That means I was drinking like 30 beers a day after work, staying awake until 2 a.m., and then getting up and working 12-hour days, Monday to Monday, 84 hours a week, no problem. If I had to work 100, I could do it. I would show up to work, somewhat not even hungover anymore. I'm way past that. It's just impossible for me to have something like that. My addictions have become so rough on my body that I actually shake and go into seizures if I don't have alcohol. And there's no other way to treat it other than to have a few beers just so I'm not shaking like a leaf and unraveling on the inside. I've tried to go to the hospital to try and help with medications and things like that, but just simply nothing works. And what I found is that the only thing that helps me is cannabis. It helps treat anxiety, depression, insomnia, loss of appetite, and it's actually now proven that it fights every single type of cancer there is. With that being said, it's far more effective than any kind of pill that you can prescribe to anybody because there is no side effects, and nobody has ever died from using cannabis either. I really feel that everybody is taking all kinds of pills for whatever ailments that they have can be solved with medical cannabis if used in the right manner. And I really feel that handing people a bunch of pills, especially opioids that has destroyed countless families, I really feel that, you know, it should be steered in a different direction if you look at it from a different point of view. Because I was hooked on opioids before, and I've almost died from 3 drug overdoses in the past. I'm still here, standing here, because I'm not ready to go yet. One of my biggest concerns right now is getting some kind of nighttime programming off the ground, because as most of you know, things happen when the sun goes down, and there's nowhere for people to go, really. So if we can get some kind of nighttime program involved that has like mental health professionals and motivational speakers, or even staff from the health unit or what have you, we need professionals pretty much 24/7. That's what I'm doing. I've been talking people out of suicide at 3 o'clock in the morning when I gotta get up at 5 to get up and go to work. And I still do this on my own time willingly. But I'm finding it very hard to do this alone, because 9 to 5 is just not working. I'm sure you guys are aware of that. You can definitely reach a lot more people if you're willing to do this at nighttime. With that being said, it seems like I'm one of the only people that are willing to go out there and do this at night, and I will continue to do this even though I'm not technically trained in mental health, nor am I a medical professional. But I'm just going to try and be positive and be there for people who just want to talk about whatever and just try to get something off their chest. And if it helps save lives, then I really don't need to get paid to do it. I'll just do it for free.
Thanks very much for that. I can't even imagine when you're going through it, you still want to contribute. So I think you open a lot of people's eyes when individuals that face the challenges like you do. It's still, you know, the perception of the community sometimes is so negative that it's important to hear those stories. So thank you. So if everybody's okay with it, we're going to have Dr. Grech, and then, well, Julian said we had to introduce you at some point, and then we'll be our last. Okay, if everybody's fine with that, thank you.
Yeah.
Hi. Hi. Okay. So.
I love your accent.
Thanks. So that's the first thing. There's a few people who may know me from clinic in here, and the first question that I'm always asked is, how do you like Kenora? And of course, the answer is I really like it. I've been here for a year. I can tell you with honesty, I love this place. Second question is, do you like to fish? No, I don't know how to. But there's so much to love about this place, and I have completely fallen in love with it. I've been here for a year. I come from a place that a lot of people would say is wonderful as well. You know, certain political standpoints in the UK are not ideal and don't fulfill my ideals, but it's a good place to live. But I've come to Kenora and fallen in love with what I would say an even better place, whether it's the nature, the town, the people, etc., everything. Except for one point, which is such an issue here and such an issue in so many, I'm sure, rural cities, is the marginalisation, the lack of advocacy, the lack of a voice for drug-using, marginalised people. We've heard from 3 at least, and that is the ones who are willing to admit that they are addicted to something. I'm sure that there is something that we are all addicted to. For me, it's chocolate. But 3 guys here who have completely opened my eyes since I've been in Kenora to honesty, politeness, a lack of violence, hardworking, and willing to do whatever it takes, whatever they can, to make this situation better than it is. And it's encouraging. It's really encouraging. Actually, the fact that this situation is occurring right now, although many of the services probably feel like they have to defend certain things that have gone on right now, of course the homeless shelter closing was not ideal. It wasn't a decision that was made locally anyway. But you're having to defend so much because there's so much attack. There is so much attack from the people who feel they have, whether it's a keyboard warrior or somebody who has misinformation that is propagating that in whatever form they're doing it through social media or just in this room right now. There's an attack and there's a defense, and that is never going to work. We just can't work on that model of attack and defense. We're all here until, what time is it now? 10 past 10. I have a 7-week-old baby at home. I have a 2-year-old. I have my wife who is, there's nobody else there with her at all. But I have chosen to put my time into this, as has everybody else in this room, as have these 3 guys who have just opened up what must have been one of the most difficult conversations they've ever expressed to anyone. But we are here, and that's encouraging. And from that, I think there's so much positive to take from it. There's always going to be dissent and negativity and us fighting against something. We see it all the time in our outreach program in the mobile van. We do get verbal abuse on the streets. But what at its core is us doing what we've been mandated to do as doctors and nurses in our situation, at least in healthcare, which is helping and showing compassion regardless of your background. And I'm so glad we're all here. Thank you. That's all I'll say. This is a good place. It's going to get better. I'm optimistic about that. And really thank you all for being here today.
I can yell.
I'm Italian, I got this. My name is Daniela. I want to thank all the presenters for all the information. I've been to a couple of these sessions now, so some of it was reiteration, some of it was new. I want to say thank you to the people who came up and gave actual suggestions and positive feedback. And I want to say thank you to the 3 gentlemen who came up here and shared their story. I'm sure it was not easy in a room full of strangers and people who clearly have certain ideas about what being an addict can mean and look like. So thank you. Thank you. Someone said, and I can't remember who, but someone said, you know, I'm sure everyone in this room knows an addict or someone who's addicted. And if you don't, I'm pretty sure everyone in this room knows someone who has mental health issues. More than one. So my question is to maybe the city, maybe to the health unit, I'm not sure who to direct it to, but we know that mental health can lead to addiction. We know that mental health can lead to homelessness. We know that mental health can lead to a number of things, and that it can probably be determined as one of the root causes of all the issues we're facing. So my question is, at what point do we say we have a mental health state of emergency? There are lack of services for everybody, but especially youth. We saw in that chart, girls age 11 to 15 are the #1 callers for, it wasn't crime, it was behavior and psychotic instances. So at what point do we say, holy shit, we need help because the services and the funding and the resources that we have are not cutting it?
We all know what the stats are, and as an organization, a policing organization, we're putting our money where our mouth is. We're running a youth mental health crisis exactly because of those stats. So I think as organizations, we have to look at the stats and put our money where it's best used and our resources where we need them, and that's what we're doing for that. So,
Sarah, did you want to?
Yeah, sure. So I'm Sarah Diaz. I'm the executive director of the local branch here for the Canadian Mental Health Association. So thank you very much for the comments, because you're absolutely right. The mental health system in our jurisdiction has been underfunded for some time, and I can say
the last time that we actually received some base funding increase was actually last year of 2.93%. So we've actually crumbled a system that is now in crisis. So what we're actually trying to do is maintain retention of qualified staff. So you have the best available services to you in this community. So you can actually receive those services close to home and you don't have to leave. The other thing that I'd also like to mention that I think Henry mentioned in one of his slides is CMHA has opened up a safe bed program that was actually funded by the Northwest Local Health Integration Network as well as the Ministry of Health and Long-Term Care. You did see a photo. It is located in the Kuwaitan area. It is a 5-bed facility. It is allows people to stay up there for 30 days for a maximum stay. For stabilization, and we do have on-site counseling. We will have on-site addiction services. Moving forward, we will have case management services moving forward. These are all enhancements that are coming now as we have opened up the facility. To date, since we've opened up May 2nd, we have had 20 individuals come through the program. The majority of them, about 90%, have been successful transitions into treatment. The majority of the issues that we're seeing are addiction related, so every comment here today has actually been very accurate on what we're seeing. And these are individuals that we have seen a few that have come 4 or 5 times for entry because they're not ready for change. But with the relationship building that we have within the actual facility, we're able to move the individuals into other services. I do have some staff here present today from the Safe Bed program, so I have to commend them because they are the ones that are actually doing the work inside the facility. But what I can say as well is there is a huge stigma in our community related to mental health and addictions. It is something that as a branch that we are trying to push forward, both through initiatives in Mental Illness Awareness Week, which is May, and I'm not sure if people are aware, but CMHA Branding just ended up celebrating 100 years of anniversary this year. And also, we also try to celebrate Mental Illness Awareness Week, which is in October. Those are 2 great initiatives I think this community needs to stand by. We need to ensure that not only we get volunteers to be able to put on events, but as well in order to collaborate with community agencies to ensure that the community understands what is actually being offered and what we need to in order to actually put forward to our politicians on what we need for mental health and addiction services within this region. Because we know there's a huge need, we have huge statistics, we are always moving that agenda forward at tables, but however, the focus has been Thunder Bay Central, and we're trying to change that with our conversations. So thank you.
All right, and with that, we are done for the evening. I'd like to, is it Daniela? Daniela, Dr. Greck, and Sarah, thank you for sending us home with a positive, there was a lot of negativity, but there was, for those people that offered positive suggestions, we thank you all. And thank you all for being a part of this tonight.
To the cost effectiveness, this comes from the Community Aid Society. It is estimated that each new case of HIV will cost $1.3 million per lifetime. The needle exchange